Well, good morning, everyone. The meeting will now come to order, and please note that the meeting is being recorded. I am not Mark Galli. I'm David Carlisle. I fall a little bit short of his stature, but I've known him a long time, so I will try to emulate him to my best ability. We'll now do a roll call.
Thank you. Secretary Dr. Mark Galli. Dr. David Carlisle.
Here.
Dr. Sandra Hernandez.
Here.
Attending virtually, thank you. Richard Cronick.
Here.
Ian Lewis.
Present.
Elizabeth Mitchell.
Here.
Attending virtually, thank you. And Dr. Richard Pan.
Here. So with that, we can establish a quorum, and I'll now turn things over to Director Landsberg.
Thank you very much, Dr. Carlisle. Good morning, everyone. Thanks for being with us, whether in person or virtually. Dr. Galli, Secretary Mark Galli sends his regrets. He is attending a behavioral health conference, actually headed to Greece shortly, and apologizes for not being here. And we appreciate Dr. Carlisle chairing today's meeting. Hopefully you have in front of you a copy of our agenda. So we are going to continue to have executive updates at the outset of the meeting, move with our consent items. We are returning to advisory committee membership, which is our one action item for the board today, with the few outstanding seats that were not voted on at the last meeting. And then we have a number of informational items today. We have thus far focused on the spending targets and definitions of total healthcare expenditures, as we should. We're very pleased to start today discussions of our other two major prongs of OCA's work, and that's cost and market impact review and some of the work on quality, on alternative payment models, on behavioral health and primary care. So we're pleased that you'll be hearing from all of Vishal Pagani's assistant deputy directors today as you get to know our staff. And we'll, of course, have time for public comment. I'll move us into the executive updates. And again, you all know that the statute is very focused on equity, as we are here at the Department of Healthcare Access and Information. HCHI's racial equity team, in addition to writing our own HCHI land acknowledgement, also has written a HCHI Black Liberation Statement, which I'll be reading today. Very appropriate, having celebrated Juneteenth yesterday, and which President Biden has as a new federal holiday as of a couple of years ago, and Governor Newsom had an executive order on Juneteenth, and we're pleased to provide our HCHI Black Liberation Statement. At HCHI, we acknowledge devastating and longstanding impacts that racism, oppression, and white supremacy have had on Black and African American communities. We acknowledge the harmful bias, discrimination, and generational trauma, as well as persistent inequities that Black communities experience, which are rooted in and serve as a reflection of our country's racist history. Black communities have been treated inhumanely by the U.S. healthcare system through enslavement, segregation, and mass incarceration, as well as being unjustly used to test advancements in medicine. Since the government has played a role in creating and perpetuating racial inequities, it is critical for governmental agencies and healthcare systems to be explicitly anti-racist in our approach to reducing and rectifying racial disparities in healthcare. At HCHI, we envision a healthcare system where doctors listen to their Black patients, center their experiences, and take proactive steps to counteract implicit bias, to provide quality care and improve patient outcomes. We envision a system that is built on mutual trust and respect between health professionals and the Black communities, and reflects the communities and cultures being served. To realize this vision, in solidarity and allyship with California's Black communities, HCHI centers and amplifies the voices of our Black partners, leaders, colleagues, and community members. We uplift Black resilience, Black education, and Black health. We commit to evaluating our efforts to actively advance justice, rectify past injustices, and guard against repeating historic wrongs. HCHI commits to using our demographic data to center the stories and experiences of Black people, identify disparities, and help generate actionable ways to work towards eliminating disparities in health outcomes. In solidarity and allyship, we commit to advancing our understanding of the Black health experience and listening to Black voices to guide us in eliminating barriers Black people face in becoming part of the health workforce and other barriers that prevent access to quality care. I want to commend to you, if you have not read the report, California Healthcare Foundation put out a wonderful report listening to Black Californians, which includes their findings from surveys, focus groups, and individual interviews. And it was the first all-staff presentation we had from our racial equity team, was to have the researchers from the California Healthcare Foundation sponsored paper come present. So there's important work being done in this area, and we're pleased to be part of it. Next, I want to give an update on the Healthcare Payments Data Program, or HPD, and we're very, very excited to say that the HPD is on track to release its first set of public reports next week. So the statute that created the HPD required us to be in substantial compliance by July 1st, which falls on a weekend. So we're taking the opportunity to start issuing some reports. We're pleased that at the July 27th HPD Advisory Committee will review the public reports and discuss data quality and completeness. The HPD data release regulations have been issued for public comment, and public comment is due by July 18th. So hopefully you are tracking that. And then in addition to our HPD Advisory Committee, we have a data release committee, which is reconvening in September to discuss data quality and completeness, including for future linkages with HPD data. And at our August affordability meeting, we will have a presentation for you about the HPD, as I know was requested, and makes a lot of sense given the synergies between the Office of Healthcare Affordability and California's All-Payer Claims Database. Also have a couple of quick updates from our Office of Health Workforce Development as we continue to help support and build the primary care and behavioral health workforces in California. So our recent program launches include a new behavioral health scholarship program and Golden State Social Opportunities program, and those are accepting applications. So we're doing everything we can to get out the word as we try to build our behavioral health workforce. Those programs support opportunities for a diverse behavioral health workforce, both to help cover their education costs and to complete their clinical training to provide behavioral health services to underserved communities. Next up, in July and August, we have our Song Brown Primary Care Residency training program grant cycle, and our Song Brown Family Nurse Practitioner and Physician Assistant program cycle. So we're excited that this cycle will also include funding for FNP/PA postgraduate fellowship programs, and this is in addition to our continued support through the Song Brown program for midwifery education. And then we're doing a lot on the pipeline side. Our pipeline or pathway programs, our Health Professions Career Opportunities program is launching in August, designed to recruit and support students from underrepresented regions and backgrounds to pursue health careers through pathway programs, which include pipeline initiatives, summer internships, and postgraduate fellowships. And it's always, I don't do a lot of site visits, but I was at Samuel Merritt University last week, actually with Secretary Becerra, and it's just great to see some of these educational opportunities and the very diverse student bodies who are the clinical, the simulation labs that they're using are quite remarkable, and we're pleased to be supporting exposure and pipeline opportunities. We had a recent Health Education and Training Workforce Council, which is focusing on behavioral health recommendations, priorities for expanding the nurse workforce, and presentations on diversity, equity, inclusion, and belonging. So we're continuing to look at all the ways we need to be supporting workforce, and the usual tools in our toolbox there's substantial funding for, but also realizing that we need to support faculty, we need to be supporting clinical placements, accelerated programs, and the like. So trying to do a lot on the workforce side to support California's health care system. So those are my department updates, and with that, I am pleased to turn it over to Vishal Pagani.
Thank you, Director Lansford. I'd like to update the board on the office as an organization, since we've grown a lot over the last few months. Last fall, I was at a CHCF briefing, and there was kind of a running joke about OCA having a staff of one, and I'm pleased to say that that's no longer the case. So, these are the three buckets that you've seen. How we're organizing the work, and that's also how we're organizing the leadership within OCA. So first, next slide, please. So here's kind of just a high level org chart. We have, under the deputy director, there are 3 assistant deputy directors. You've met CJ Howard at the last meeting. He oversees the healthcare spending targets branch, where he oversees efforts to implement and monitor entity performance against spending targets. Additionally, the branch is tasked with managing OCA's public engagement and internal administrative activities. A former educator, CJ has spent much of the last decade administering programs within the Health and Human Services Agency, including HCI and CDPH, where he worked on workforce development and healthcare facility regulatory programs. And then in the middle, we have Margaretta Brandt, who's the Assistant Deputy Director for Health System Performance. She oversees the development and implementation of OCA's efforts to promote a value-based healthcare system by measuring quality, equity, adoption of alternative payment models, investment in primary care and behavioral health, and workforce stability. Margaretta was previously the Quality Improvement Manager for Covered California, where she led efforts to improve healthcare quality and implement delivery system and payment reforms. Before joining Covered California, Margaretta worked at a nonprofit coalition of healthcare providers and community organizations, where she facilitated a collaborative quality improvement initiative for 12 community clinics. And then last on here on the right is Sheila Tatayan, Assistant Deputy Director for Health System Compliance. You'll also be hearing from her later in the agenda. Sheila oversees OCA's efforts to monitor the impact of market consolidation on cost trends and reviewing prospective transactions that could hurt competition and affordability in California's market. She has over 30 years of experience in advising healthcare organizations, including state agencies and health plans. Sheila has provided legal counsel to healthcare clients on compliance audits, HIPAA, breach investigations, corporate acquisition filings, and antitrust risks of hospital mergers. She has also represented the Department of Managed Healthcare in administrative and civil litigation on matters related to access to care, provider directories, and health plan delegation to physician organizations. Next slide. So, in addition to the leadership team, we also have several great staff that have joined us. We've made significant progress in hiring. We've hired 3 new health program specialists in the engagement and governance group led by Megan Brubaker, 5 new attorneys under Sheila in the health system compliance branch, and 2 new analysts in Jonathan Chavez in the administration and management support unit, which reports up to CJ Howard. We also have a number of recruitments in progress. These are listed on the right. There's about 14 of them. They range from attorney positions at the assistant chief counsel, classification, pharmacy consultant, and then several other analytical classifications and research classifications. Several of these are in flight. Some of these we may be interviewing for, but if you know of any great candidates, please let them know to look for future openings and as well as these existing postings, and would appreciate any help getting the word out. Next, I'd like to remind the board about the slide formatting. We covered this in our last meeting, just to make it more clear, to orient the discussion. So we will use a yellow area in the presentation for areas over which OCA or the office has decision-making authority. It's important to get stakeholder input on these areas, and these meetings are an important way to engage with both the board and members of the public. For areas where the board has ultimate decision-making authority, we note it with a green arrow. And I'll now turn it back over to the chair.
Well, thank you, Director Landsberg and Deputy Director Pegany for those great presentations. I will now go on to invite public comment related to the executive updates provided by the Director and Deputy Director.
Great. We will now recognize members of the public for comment on that agenda item. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in this room may line up at the podium. Those attending virtually who want to comment should click the raise hand button. Those dialing in can press *5 to raise your hand. It will track the order in which the hands were raised. During the public comment period, you will be unmuted when it is your turn. Please note that while the Healthcare Affordability Board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. I will start with the individuals in the room, noting no one at the podium. I will turn virtually, noting no raised hands. We'll give it a moment. All right, seeing no public comment, we'll move on.
Well, thank you. And let's see, next we go to our action consent items. And the first one is a question of Ian. Which is to confirm you will be attending the advisory committee meeting that is taking place tomorrow, June 21st?
I will.
Excellent. Okay. And now we'll turn over to the next item and go to the approval of the May meeting minutes. Deputy Director Pegany.
As a reminder, consent items are routine procedural decisions and decisions where we do not anticipate discussion or debate. The items will be considered together and acted on in one motion. The first one we have is the meeting minutes from May. They've been distributed and include written public comment we've received since the May meeting. And then next up, we have approval for 2 board members to attend the September and November advisory committee meeting. These respectively, this would be Richard Pan for the September meeting, and then both Rick Kroenig and Sandra Hernandez to attend the November meeting. And then I'll turn it back over to the chair for a motion.
Great. So can I get a motion to approve the action consent items 3A and 3B?
So moved.
I'm happy to move those, David.
Thank you. Thank you. And we next go on to invite public comment once again.
We will now invite public comment. If you're in the room, please step to the podium. If you're online, please raise your hand. Noting no one in the room, we'll turn virtually. Noting no hands raised, we'll close public comment.
Any additional discussion from the board? And seeing none, action consent items 3A and 3B are approved. Thank you. We'll now move on to item 4, action items.
Sorry, do we need a vote?
We need a roll call vote.
Need a roll call.
Roll call vote, excuse me. First trip.
All right. Dr. Mark Alley, noted as absent. Dr. David Carlisle,
Aye.
Dr. Sandra Hernandez,
Aye.
Richard Kroenig,
Aye.
Ian Lewis,
Aye.
Elizabeth Mitchell,
Aye.
Dr. Richard Pan.
Aye.
Okay. Action consent items 3A and 3B are approved. We'll now move on to item 4. I'll turn it over to the OCA Assistant Deputy Director, CJ Howard.
Good morning, Chair, Board, members of the public. My name is CJ Howard, the Assistant Deputy Director over the Healthcare Spending Targets Branch. As you will likely recall, last month we made substantial progress as a board and the subcommittee to appoint the advisory committee, appointing 23 members in total, and we were given some homework to come back to the board this month. So at the May board meeting, the board tasked the subcommittee with revisiting the healthcare worker category with a focus on finding frontline healthcare workers to serve on the committee and identifying an individual that would represent the public sector labor union perspective in the organized labor category. So this is what the current committee membership looks like. Again, made substantial progress towards appointing most of the categories that we had discussed last month, holding open the 3 slots in the healthcare workers, and then adding an additional organized labor position. So just a little bit of background as we get into the proposed, so context setting as we get into the proposed membership for the healthcare workers front. So representing healthcare workers, based off of the total applications that we received 43 applications where people self-identified as representing healthcare workers. Only 6 of those total applications were current frontline workers. We also were looking for people that had behavioral health experience, or at least as self-attested. We only found 1 current frontline worker that was in a non-supervisory position. So it's just a little context setting for the individuals that the subcommittee is putting forward for your broader consideration. So in the recommended slate, we have Stephanie Klein, who is a respiratory therapist, Sarah Gavin, who's currently working in an FQHC, albeit I will note in a management or supervisory role, has a background in behavioral health. And then also Sarah Sorokin, who's a current behavioral health practitioner in Solano County Mental Health. And then additionally in the organized labor category, the subcommittee is recommending Janice O'Malley from the American Federation of State, County, and Municipal Employees. So the draft motion from the subcommittee is to approve the 3 proposed members under the healthcare workers category, approve the additional organized labor proposed member, and then additionally to allow OCA staff to randomly assign the new members to either a 1 or 2 year term, as we discussed last meeting. Half of the initial appointments would serve a 1 year period, and then we would get into a routine of filling half of the advisory committee each year. So with that, I'll leave it, maybe I'll tee it up for Dr. Pan or Elizabeth Mitchell if you'd like to add any other context about our discussions that we had that I may have glossed over all too abruptly this morning.
Dr. Pan.
Well, I would just say is that I think we went through 3 rounds of solicitations for this initial committee. I actually hope that as we do randomize people for their terms and so forth, that we continue to, in future rounds, solicit. I mean, but I think we have a good initial group to start with, given who the nominees that we received. I would make note that one of the things that did come up was, did the person have to be a resident of California? Because we have people who work in California who actually don't reside. We decided that they should be residents of California, so that did leave some nominees out. But we felt that that would be an appropriate policy. Whether the board wants to adopt that formally or not in a future date, it's another issue when we do another round. But that was actually a consideration that came up during our deliberations. But this is our set of nominees we're proposing. I would make note that the advisory committee meetings are public, just like our boards, and people can weigh in at those meetings as well. So there is public input as well to the advisory committee. And so, I think we tried to do our best, and I think hopefully we can get the advisory committee moving forward and then continue to seek out additional qualified people as we roll forward. As there's turnover on the advisory committee, I'm sure there will be in a group that large. Thank you.
Other comments or discussion points?
Elizabeth.
Hi, thank you. I echo Dr. Pan's comments. We did put in quite a bit of diligence into going through the applicants that we received. The only thing I would say, and this was not resolved, is that I remain somewhat concerned about the overall balance of those subject to the targets and those who are paying for care. I believe that the candidates that we have put forward are strong. I still think if the board were to decide to add another representative on the purchaser side, that might go a ways towards solving that imbalance. But I support the slate as it has come to the committee or the board.
Thank you. And Don Moles?
Yeah, I just wanted to resurface a comment that I made last board meeting, which is that, you know, I felt like it was an omission not to have a retiree on the committee, and also that it was a missed opportunity to exclude all of the academics who were up for consideration. Looking at Massachusetts as a model, I know that we've looked to, you know, that commission had strong academic representation. I think it's important to have people who know the literature, the peer-reviewed literature in this space. It makes conversations less anecdotal and more evidence informed, and I just think that is a pretty serious omission as well. So, you know, have a strong application from the vice chair of the California State Retirees Association, who serves a dual purpose on this, both representing retirees, but also a consumer of healthcare on the public sector side, which is an important piece. You know, we have a lot of folks in California who receive their healthcare that way. Their healthcare looks very different. I think it's an important voice to include.
Thank you. Yes, Ian.
Thanks. I share Elizabeth and Don's observations. It also doesn't quite sit right with me that somebody in a managerial capacity be categorized as a healthcare worker, quote unquote. That said, I think I at least will have an ear towards tilts in one direction or another with regard to workers or with regard to consumers versus regulated entities in listening to the advisory committee's advice. I'm not going to let the perfect stand in the way of the good in this case, and would support this recommendation. I do wonder if Richard or Elizabeth or others here kind of reactions to Don's suggestion and whether you'd be open to adding that representative.
Other comments or responses, Dr. Pan? Or did Sandra Hernandez? Or Elizabeth? Yes.
I would be supportive to Don's recommendations.
As would I, David. I think his points are well taken. And I just want to add my appreciation to the subcommittee. I know a ton of work, and I too agree with we should not let perfection be the enemy of good here.
Thank you. Thank you. Dr. Pan, a comment?
Yeah, no, I appreciate the discussion. You know, again, we're not trying to be overly rigid, but you know, one of the principles we set out before we started, so before we start putting any names or slots or anything, was how big the committee is going to be and versus its function. You know, one can always argue on the margin, is adding just one more person going to be a problem? But then you start creeping, right? And we realize that there are, you know, essentially quote unquote, you know, call them missing voices on the actual advisory committee itself. I would make notice in our deliberations that, for example, you know, I'm an academic myself, that the academic voice would also, this is not the only committee. I mean, this is the one in statute and that we make a decision, but this is not the only committee that gives input to this board or to the agency. So we wanted to recognize that. And also this committee itself can be informed by people just in the same way that we are, right? So despite, you know, the wonderful expertise that's already on the board, obviously we are going to be advised by even people who have greater expertise. And in fact, I think many of us in our other roles that aren't on this board are also advised by people who have greater expertise, because none of us actually has all of it in our brain, except perhaps Dr. Kronik, whose accomplishments are, beyond certainly mine. So
Was that a lateral to Professor Cronin?
I certainly do not, and would appreciate hearing from the advisory committee, or having on the advisory committee, both a retiree representative as well as at least one academic who could, as Don said, bring evidence to bear, which, many of the other people, and I appreciate the work that you've done, and obviously there'll be a lot of expertise among the advisory committee members that we've already voted for. But I mean, self-serving, I am an academic, but I do think we have something to add here.
Yeah, and I would, and I think some part of our deliberation also wasn't that, we recognize that we actually have people on the board, and that maybe they advise, and actually they advise us. So some of that perspective is actually already present on the board. So I guess, if we want to add one more person, right? But I just a little concerned about the, there's always let's add another person, and then we set out the discussion, right? Before we had all the slots and so forth, we said, well, this is how big the board should be. And so again, it's not a rigid number, because one more person can tip the difference, but I just want to be a little cautious about, we keep adding another person, then the function of the board, of the advisory committee itself, can get affected and so forth. And I would also make note that in our discussion is that it's not like the advisory committee has a vote and then only one viewpoint is sent to us, right? I mean, we are going to hear the diversity of opinion of not only people on the advisory committee, but the input they got. Of course, people can directly come into the board as well. So, I think we tried to strike a certain balance in what we have here in terms of, number proportion. And I do think that, and we actually looked at the numbers in terms of, who's regulated and who, et cetera, and actually the balance, again, we can bring up that pie chart again. I think there's implications of not that balanced. Actually, it's pretty balanced. And I just, I remind you the presentation we had before we filled in the first presentation, we actually took a look at that as well. So, if we want to add, one more retiree, okay, it's a decision of this board, but I also just want to make note that in our deliberation, we start off by saying, how big should this board be, right? And I just want to keep that context there, because we're creeping larger and larger and larger. And would one more person really cause all that chaos? No, but at a certain point, and we've all been on these boards, it starts getting a little large and it gets a little unwieldy, and then it doesn't function as well as we'd like it to. So I just put that caution out there. It's easy to look for the holes and say, but and the other thing I would also make note is we looked at each person, so we sort of have them in these little categories, right? We have the things on the top. We did look at their applications, we delved through to look at not just what, their surface category was, but also looked at their experiences and things that they brought to the board, and not just like, their one spot. So I won't pick out any particular person, but they often brought experiences beyond simply their current position and job, whether in the past or even in the present, right? So many of us don't just do our job, but we also have other roles and so forth. And those experiences get brought in because we're appointing people. We're not appointing organizations, right? We're not appointing someone to be this organization on the board. We're actually appointing people who bring in the group of their experiences. So of course, in the end, it's the decision of this board, what it wants to do, if it wants to increase by another 1, 2, 5, whatever else. But I just want to let you know that when we started off, we said, this is the size we think is going to be functional, and we're ready beyond that. And so I just caution continuing to add additional people to the advisory committee.
I see we have another comment from Elizabeth.
Yeah, sorry, Mr. Chair, just wondering if there is a motion to add the retiree and the academic, and just wondering about the procedure.
I would add for the retiree, I do want to point out that Abby Yont from the San Francisco Health Service System is a purchaser that purchases on behalf of retirees.
I can't.
Don, I can't quite hear you. Todd, could you repeat what you said?
I was just differentiating between somebody who's receiving healthcare as a retiree and someone who is purchasing healthcare on behalf of retirees.
So as the staff who will be facilitating this advisory committee do share Dr. Pan's view. So the slate currently is 27. So if we were to add 2 more, 29. So we did have a discussion about the difference between 25-ish versus 30-ish is substantial. And Don, is there a particular person that you're suggesting has applied that you're putting forward?
The person that I had been advocating for on the retiree side was Tom Constantine, who is one of our he's on the committee, the health committee of the State Retirees Association. There are multiple high quality academics. My main concern was having someone with that voice in these conversations. I wouldn't, given the concerns about size, I wouldn't be advocating for multiple voices. Presumably we'd be rotating, but I do think even adding one would be meaningful.
Dr. Carlisle, if I might make a recommendation
Sandra,
here.
go ahead.
I would
Yes.
move the recommendations that the subcommittee put forward and ask that at the next year's membership, we look specifically at a retiree as part of our consumer patient group category and look to add someone or more than one with academic backgrounds. We should get started. I think 30 is a big group. I concur with that notion and with staff on that. And that would allow us to move forward with this group in a year from now when some folks come off as per the random assignment, we could pay attention to these additional categories.
So I think we've heard a motion to the board. And from Sandra Hernandez, is there a second to her motion?
I'll second.
Great. Okay. Well, we will now invite public comment. Thank you.
We'll now take public comment, looking to the room, noticing someone coming to the podium. Please go ahead.
Can't hear the speaker. Can't hear the speaker.
Thank you, Dr. Hernandez. Beth Capel on behalf of Teamsters and Unite Here. Just to note that none of the public have seen any of the applications and only have the information that is shared in the public domain. We regret to oppose the manager who suggested as a healthcare worker. We do not oppose the inclusion of a community clinic or someone with behavioral health experience, but they are not a frontline healthcare worker. They are a supervisor. We commend to you the addition of Janice O'Malley to Joan Allen, Carmen Costi, and Ivana, whose last name I can't pronounce, from Unite Here Health as well. And we would also commend to you Kathy Bassler, who is from CFT, from the folks from Monterey who you have heard so much from in such a moving way. We appreciate the board's discussion, and we have no information about Ms. Gavin beyond what's available in the public domain, but she is a manager. She's part of the executive team at that community clinic. And to us, that means she is not a frontline healthcare worker. Thank you.
Looking virtually for public comment, seeing no hands raised, going back to the room at the podium. Go ahead.
Thank you, Joan Allen, SEIU United Healthcare Workers. Would echo Beth Capel's concerns about categorizing a manager as a frontline healthcare worker. Based on the discussion that we heard last meeting, there was the concern that we could not have people who are representatives of frontline healthcare workers in that frontline healthcare worker category. And there was quite a bit of discussion of that. And therefore would say that someone whose title is director is would neither be eligible to be a frontline healthcare worker nor a representative thereof. Would also say that it does move one more person who is there to represent a regulated entity, as opposed to the other two healthcare workers who are there to represent frontline healthcare workers. So would recommend that that individual not move forward, but would support the other names that are up for consideration. Thank you.
Turning back virtually for public comment, noticing no hands raised and no additional public comment in the room. Public comment is closed.
Thank you. Well, we now have a motion before the board from Dr. Hernandez. Dr. Hernandez, did you want to repeat the motion?
I'm proposing that we move forward with the subcommittee's recommendations as they've been brought forward today, and an explicit recommendation that a year from now, when we have transitions off of the committee, that we appoint a retiree and consider additional academics to join in an appropriate category.
I think we have another comment from Elizabeth Lewis.
Mitchell.
Mitchell, excuse me.
I'm supportive of Dr. Hernandez's motion, but would also consider offer a friendly amendment to also include a small business representative next year, along with the retiree in the academic seat.
Yes.
I'll let Dr. Hernandez speak.
No, please go ahead, Ian.
Well, a question I wanted to ask staff on the question of frontline worker applications. How many non-managerial actual worker applications have we considered and overlooked in favor of the managerial position?
So yeah, we received 6 frontline worker applications. One of those was an out-of-state worker, and then the other applicants just did not rise up in the estimation of the subcommittee.
But for the 2?
Correct.
Thank you.
Okay. Yes, Dr. Cronick.
Add to Ian's question, and CJ, you did when you presented the slate note that one of the names is not a frontline worker, and I gather that the decision was made to prioritize behavioral health expertise over kind of really being a frontline worker. Was that the case? And why is it? Maybe better question for Dr. Pan or for Elizabeth. Why did you choose to suggest a person in the frontline worker slot who is not a frontline worker?
So I would make note, first of all, I think earlier on we had said that we needed more behavioral health representation, both on the on the provider side as well as on the patient consumer advocate side. I would make note that well, certainly, and again, this is about part about the person not just being the title that they have, is that we don't have someone who's explicitly from a mental health organization like NAMI or something on the patient group, et cetera, side, but we have people bring those experiences, right? As well as, of course, CPEN having that work. So I think, this is part of the struggle where, the work that we were trying to do as the subcommittee. I would make note that, recognize how important behavioral health was. We were looking through for people who had, actual practice experience, not just experience, but recent activity so, I mean, the person does have a title director. They also, they also have a role in taking care of patients, right? So, and so that is part of the lens through which we tried to look at. And I think we were trying to say, okay, well, given that we've done 3 solicitations, this is where we're at. And I think as you heard, and I appreciate Dr. Hernandez's motion is that, this board can also, when people are up in a year or two, they'll be randomized year or two, relook and say, okay, well, now we have, as I said in my openings, that, we can now solicit more people and hopefully we have a larger pool, and then there'll be turnover on the board, but also we can perhaps fill in some of the, replace some of the gaps and so forth. But we did also want to have a committee that could move forward, because said we're having a next meeting tomorrow, right? So we wanted to get the committee to move forward, and then I think, given the applicant pool, I think this is the best, with 3 solicitations. I mean, this is, and where we were explicitly saying we were looking for people with particular background. I think we tried to do the best we could with what we got. And so that's why I think that's why we are here where we are, and that's why we're proposing the slate as it is. So I think that Jared Gavin, who is a director at a community health center, right, is also a clinician who also sees patients, and so that's that's the lens through which we were looking at that particular nominee.
I will just add, I mean, had there been another quote, frontline healthcare worker that was a viable candidate, I think the subcommittee would have certainly been amenable to that. And to Ms. Capel's point, I mean, we understand that the full applications, all 140, however many of them, weren't made available. But for Ms. Gavin, for example, there was discussion about her previous work, her previous clinical work, and also personal experience and diversity criteria. So it was a holistic review of the applications. But I'm actually surprised that the pie chart, which I'm not saying the pie chart is wrong, says 6, because I don't think there was another viable candidate that we could have put forward.
Okay, well, I think we have a motion on the floor with an amendment from Board Member Mitchell. I think we have to ask Dr. Hernandez if she wants to accept the amendment. Yes, Dr. Pan.
So
I'm happy to.
So actually, let me just make a comment about the amendment. I mean, I'm fine with given, if there's a turnover in purchasers, never objected to having a small business person in the purchaser side of things. But again, I go back to the size of the board. So if it's an add-on, so I think we're looking at opportunities when there's turnover. So I'm certainly open to, I just want to be sure that that's clear what we're trying to say there, is that it's not an add-on, it's a, it's a gap that we want to, perhaps this board is explicitly pointing out, there's turnover on this advisory committee.
Yeah, that was the spirit of my motion, Senator Pan, is that these additional qualities or capabilities or experience would plug into the existing categories with a goal to continue to try to contain the membership as we've done thus far. So I'm happy to accept the amendment, friendly amendment, with that caveat.
Yes.
And I suspect, given the size of this committee, that not everybody is going to be at every meeting. And I'd ask, I mean, especially Elizabeth Landsberg as the chair of the committee, if attendance tends to be substantial, significantly less than the full committee at every meeting, we might revisit between now and a year from now, adding a couple of slots in recognition of that, and keeping a close eye to Don's suggestion and Elizabeth's suggestion.
Okay, well, I think we will call the vote now.
Mark Galley. David Carlisle.
Aye.
Sandra Hernandez.
Aye.
Richard Kroenig.
Aye.
Ian Lewis.
Aye.
Elizabeth Mitchell.
Aye.
Richard Pan.
Aye.
Well, since the motion has changed, since we received public comment, we will revisit public comment.
Now open for public comment. If you're online, please raise your hand or press *5. In the room, please come to the podium. Going to public comment in the room.
Beth Capel on behalf of Teamsters and Unite Here. Since you voted already, it seems a bit, but I appreciate the opportunity for public comment. Many managers and directors previously had experience as frontline workers. Once they cross the line, they're in a different role in the same way that someone who's a retiree is different than a purchaser of care. It is a different role and a different responsibility. The community clinics will be subject to the targets in the same way that other healthcare entities are, if my recollection serves. And so it is not, again, anything with respect to Ms. Gavin or an FQHC or behavioral health, but it is, if she is going to be a member of this committee, we would ask that she not be categorized as a frontline worker. That would be the other way to solve this problem. So thank you.
Moving to public comment virtually, seeing no hands raised.
Well, thank you. We will go forward and let the vote stand as taken. Thank you. So the advisory committee membership is now approved. We'll now move on to item 5, informational items.
So this is an informational item for cost and market impact review. Kicking off this discussion is Katie Goodixson. Katie is the executive editor of The Source on Healthcare Price and Competition, an independent nonprofit initiative at the University of California, College of the Law, San Francisco. The Source provides research and expert opinions on healthcare reform and the drivers of healthcare costs, with a special interest in market consolidation and state policies to address market power. In her 5 years at The Source, Dr. Goodixson has written over 24 papers, drafted model legislation to improve state merger review processes, and to prohibit anti-competitive terms in contracts between health insurers and health systems, and has testified in state legislatures. Using this expertise, Dr. Goodixson and the Source team advised the staff at OCA on the implementation of the CMIR program. Thank you, Katie, for your attendance here, and take it away.
Thank you. And good morning to the board and members of the public. I've been asked here to talk to you this morning a little bit about a very large and growing body of research about the impact of consolidation in healthcare. I'll give you some national trends and some trends in California. First, I just want to start out with kind of the global impacts, what the research tells us about consolidation. And the very best studied of these consolidations are hospital consolidations. So there's many, many studies going back decades showing very consistent results about mergers within a market. So if two hospitals within a geographic market merge. In general, the research shows us that hospital prices increase by about 20 to 44%, and there are documented cases that are even higher than that. And there's also quite a bit of research showing that bystander hospitals, so those are hospitals that weren't involved in the merger, also raise their prices, basically shadow pricing the price increases in that area. There's a growing body of research about cross-market consolidation. I'll talk a little more about that in a minute, but these are consolidation where a health system or a hospital merges with a hospital in a new region. So traditional antitrust theory would tell you there's no likely harm because they're not competing for patients. But the documented economic studies show that prices rise by about 7 to 9% at the acquiring hospitals. That's the health system doing the purchasing, about 17% at acquired hospitals, and that's best documented with an out-of-state purchaser. And again, there's evidence that bystander hospitals also raise prices. On quality, the evidence is a bit more mixed, but most studies fail to find any real statistically significant impact following a particular merger. A few studies show modest improvement of a few measures, especially in process mergers, but generally, most studies on hospital quality measures find that quality is lower in less consolidated, less competitive, highly concentrated markets. And in particular, there's higher mortality and worse outcomes. So given these studies on price and quality, it's concerning that most hospital markets are already very concentrated. So back in 2017, the Congressional Budget Office found that hospital markets in 70% of metropolitan areas in the US exceeded concentrations that the DOJ and FTC found highly concentrated, and only 6%, and this is about 5 years ago, only 6% were considered competitive. And so while mergers among hospitals in the same city are still happening, frankly, a lot of these mergers have already happened. So I'm going to spend just a minute here talking about two newer trends in consolidation. And the first is expansion into regional and national systems. This is essentially the cross-market mergers that I talked about. This map shows the 5 largest hospital systems by number of hospitals, and this is data from 2019. Each dot on the map represents the location of a hospital, and the size of the dot is based on the number of admissions each year. Hospitals with the same color, or dots of the same color, are parts of the same system. So collectively, these 5 systems have 539 community hospitals in 43 states. This is over 10% of the hospitals in the US are members of these 5 systems, and their revenue over the last 10 years has grown at twice the rate of the rest of the market. And the other major trend in the last few years is in vertical integration, and that's the acquisition of physician groups or other clinics by health systems, insurance companies, and corporate ownership like private equity groups. So when physicians work directly for hospitals rather than an independent practice, there could be greater efficiencies through economies of scale, better quality care for patients through coordinated care and information sharing. And integration with health systems could also reduce administrative burden on physicians and reduce duplicative services. But the research evidence demonstrates potential harms. So in particular, health system ownership has shown that it can lead to increased costs and increased use of high intensity services. For example, 2 studies recently found significant increases in inappropriate imaging studies. For example, physicians ordered more MRIs, and in particular, inappropriate MRIs when they transitioned to hospital employment. Similar effects were found with colonoscopies. It depends on the specialty exactly what the results were found. But in general, it's higher prices and spending and higher use of high intensity services, in particular at the hospital where the physicians are employed. Similar effects have been found when physicians transition to private equity or corporate ownership, higher prices, increased utilization of high-cost services. Here, there's more evidence of mixed quality measures and lower patient experience scores. On the right here, you can see a graph that actually shows the percentage of physicians in each of those types of employment. And you can see since 2019, there's been a decrease in independent practice and then an increase in health system and corporate ownership. And in particular, the health system ownership really jumped in the early 2010s, and now it's leveled off a little bit with the increase in corporate ownership growing now. And in particular, I want to spend just a moment on private equity ownership because it has been more in the news more often and sort of spoken about. And this map was generated by researchers at Johns Hopkins and Harvard, and it was published in JAMA Health Forum. And it shows the share of physicians in private equity acquired practices for 6 specialties: dermatology, gastroenterology, ophthalmology, obstetrics, gynecology, orthopedics, and urology. And the darkest color here shows the highest quartile of private equity ownership, with up to 1/3 of specialists in these areas owned by private equity firms. And you can see that it's concentrated in the Northeast, Florida, and Arizona, but there's also areas of significant private equity ownership in some areas of California, in particular, the southern, actually you can see the map, you can see where the dark color is. And this distribution implies that acquisitions in different specialties in different areas of the country by different buyers may have significantly different impacts on healthcare markets. So in these markets, even small transactions might have big impacts. And it's important to evaluate even smaller transactions based on what else is going on in those markets. So turning now specifically to California, the trends are similar. This graph is from researchers at the Petra Center at UC Berkeley and was published in Health Affairs. The solid line here shows the level of horizontal consolidation as measured by the Herfindahl-Hirschman Index, and that's a measure that federal antitrust enforcers use to determine concentration, and basically any number over 2,500, So I was trying to use the pointer there. Anything over 2,500 here, the scale here is on the right, is considered concerning. And you can see that primary care physicians are sort of hovering around that number, but every other insurers, specialists, and hospitals are well above that concerning level. And you'll also note that, as I said, sort of they're relatively horizontal lines, basically because a lot of the horizontal consolidation has already happened. What's really been trending up is the dotted lines, which are vertical integration. I know it's a little hard to see here. So those same authors actually published another study specifically about vertical integration. This is the same data, and then they added a few more years. And you can see that from 2010 to 2018, primary care physicians in California that are in practices owned by a hospital or health system grew from about 25% to 42%, and specialists grew from about 25% to over 50%. And the real concern here is that these vertical acquisitions happen without a lot of oversight. Large transactions have to report to the federal government, the FTC and the DOJ, before they happen. But this year, that threshold is $111.4 million, so very, very few physician acquisitions rise to that level. At the federal level, there is understanding that there is a gap in oversight. Early in administration, President Biden issued an executive order on promoting competition in the American economy. He set up a whole of government approach that created a new competition council and tasked a dozen federal agencies with invigorating competition. And he identified healthcare as an industry of concern. Earlier this year, the Department of Justice withdrew its policies on healthcare antitrust safety zones that used to have safe harbors for small hospitals, so those with fewer than 100 licensed beds, or physician joint ventures involving 20% of less of physicians in the geographic market. Those have now been removed, and they don't have safe harbor policies at current. And on the congressional side, House Energy and Commerce bill would require, if it passes, providers to report ownership and submit an annual report about any mergers or acquisitions to the Department of Health and Human Services, and then that report would be made publicly available. While it still remains to be seen if this bill gets passed, it does have bipartisan support, and it passed out of committee unanimously last month. Not waiting for federal action, many states are also trying to increase transparency and oversight of healthcare mergers. I have a map here that shows states that require providers to file notice with a state agency before a merger. And I recognize that there's a wide variation of requirements across the country. There's a lot of different ways that mergers get reported. In the gray color are states that don't require any pre-merger notification that is specific to healthcare. The three lighter blue colors require notice to a state agency, a certificate of need program, or the AG for specific healthcare transactions. Typically, these are nonprofit hospitals. And in the darkest color, there are 6 of them, are states that have passed laws requiring notice of all hospital and most provider merger groups. I have included California, New York, Illinois, and Minnesota that all passed laws recently and will be starting to collect notices in January. And these states require hospitals or most provider groups to give notice either to the AG or another state agency before a transaction occurs. And I want to hone in on the 3 states that actually have an independent agency an agency that's specifically tasked with oversight of the healthcare market. So we've all talked a lot about Massachusetts. The Health Policy Commission has been collecting notices of proposed transactions for over a decade. In Massachusetts, providers with over 25 million in patient revenue have to file a material change notice with the HPC before they can close many transactions. The HPC then has 60 days to decide whether or not to do a cost and market impact report. And the parties can't complete the transaction until the HPC issues their cost and market impact report. But it's important to note that the HPC actually doesn't have the ability to block or place conditions on a transaction. If they find a transaction is particularly concerning, they must rely on the AG or another state agency with the authority to do that. In Massachusetts, this other agency is typically the Department of Health, which actually does have the ability to block transfers of ownership. Since 2013, that's the first year that they began collecting these notices. The HPC has collected and published material change notices for 155 transactions, and they've done cost and market impact reviews on 9 of them, with 2 of them pending. In Oregon, the Oregon legislature created this program in 2021, and it has some key differences from Massachusetts. So with a few statutory exemptions, it applies to all healthcare entities, including plans and insurers. Massachusetts, as I said, only applies to providers. And the typical exemptions are long-term care facilities. And the HCMO program in Oregon has a two-stage review that's similar to Massachusetts, with the caveat that in the comprehensive review, which is similar to a CMIR, they are empowered to have a community review board that very specifically solicits input from members of the community about the impact of that transaction. And then the biggest difference is that the Oregon Health Authority actually has the ability to block or place conditions on transactions. So they don't have to rely on the AG or another agency to block or place conditions on a merger. I'm not going to talk too much about California because Sheila's going to handle that, but I'm just going to say that it's very similar to Massachusetts in the authority, with the caveat that it actually applies to a broader sense of healthcare entities, not just providers. And because the authority in California is very similar to Massachusetts, I wanted to give you just one concrete example of how this process has worked there. So in July 2017, Lahey Health and Beth Israel, which are two of the largest and most well-established health systems in Massachusetts, submitted a material change notice to merge. So this merger would make it the second largest healthcare system in the state after Partners Healthcare. So after a 30-day review, the HPC determined that it was likely to have a significant impact on market function and sent it to get a cost and market impact report. So the HPC then conducted a preliminary report and issued it in July of 2018. The parties were allowed a period to comment, and a final report was issued in September of 2018. And the HPC had three primary concerns. They thought that there was a high likelihood of substantially increased commercial prices, that claims that the parties made of improved quality and care delivery weren't well substantiated, and that Beth Israel Lahey Health would have the lowest mix of Medicaid patients and the lowest proportion of non-white and Hispanic emergency department visits among all hospitals in Eastern Massachusetts. So the HPC then referred their final report to the AG and made recommendations to the Department of Health to impose conditions. So in October of 2018, the AG entered into a consent decree with conditions that kind of mirrored exactly what the HPC had suggested. They imposed 7 years of price caps on the system. They demanded that Beth Israel Lahey place no caps on the number of Medicaid patients they saw, and to actually advertise to try and increase the number of Medicaid patients they saw. And they required them to invest at least $70 million to expand healthcare access to underserved communities in Massachusetts. And the Department of Health imposed similar conditions in its approval as well. So the takeaways that I want to leave you with are that the HPC conducted a very thorough and transparent review on the likely impacts of the merger. And they used data and expertise at the HPC. The AG and the Department of Health relied on this independent agency to do a lot of the expertise and sort of analysis for them. And then they relied heavily on that. And in the AG's case, the judge, when they went to court to try and place these conditions, the judge found the HPC's report very compelling. And I think a similar process could take place in California. And I'll stop here and ask if you have any questions about consolidation generally or about other states before I turn it over to Sheila to talk about California.
Dr. Khan.
Thank you so much. Thank you so much for your presentation. One of the things I just want to make note, I guess it's the slide you had on M&A trends, private equity owned physician practices, that map. So because you made note that, for example, Arizona and Florida had the most, and just sort of looking at the distribution, I mean, those are where at least I believe a lot of retirees are, so I assume Medicare patients. So is there something about Medicare that is particularly appealing to, I guess, private equity? Because it seems like they're particularly targeting states where there's a large percentage of retirees who, I presume many of them are seniors who would be covered by Medicare. So I don't know if that's a misperception just looking at the map, but I didn't know whether you had some insights on that.
I think that it is certainly an interesting observation that requires further study. This paper also went into particular specialties, and I actually don't remember. For example, if gynecology was very highly concentrated in those states, you'd expect that not to be Medicare related to Medicare, for example.
Well, I
but-
would suspect, for example, oncology might be one of the fields to look at, et cetera. So anyway, just looking at the map, and this is just, I'd be interested in know. I just want to know whether you had some further insights or other research, but perhaps.
Yes.
If I can follow up on that, but I also had a question about this map. There is some, at least speculation, I don't know, strong evidence about the attractiveness of Medicare Advantage to private equity firms, and Medicare Advantage is also, fairly high penetration in those states. But the question I had, and thank you for the presentation about this map, is I know you're aware of the prohibition in California against the corporate practice of medicine, and how is it that private equity can purchase medical groups in California and not run afoul of the corporate practice of medicine prohibition?
This is certainly something that is a current topic of discussion in the academic literature, and also there are many states that are considering either enhanced enforcement or following California's lead in corporate practice of medicine. But many times there are ways that a private equity group could take over all the non-clinical decisions and exert some kind of ownership without actually being involved in any of the clinical decisions. There's also the establishing a friendly provider at the top of the organization that oversees the physician groups as well. So that would be a clinician, but that clinician would be a physician in terms of that oversees then the groups that own the physicians. It looks like I didn't answer your question.
Well, I'm not a lawyer, and I don't actually know that law very well at all, except that it exists, but I am still a bit confused.
Okay, online we have Elizabeth Mitchell and then Dr. Hernandez.
Great. Thank you, Katie. I have two questions. I'm familiar with the research you cited on the increase in prices, decrease in quality associated with mergers and acquisitions, but has there been any research on access? We are seeing a growing access crisis, particularly for primary and maternal care. And I know that when some health plans purchase practices, they then limit access to other plans. I'm just wondering if there's been any study on access impact. And then I have another question after that.
Yeah, so I anticipated that question. So I went and looked up a bunch of the literature last night, and what I would say is there are a lot of very anecdotal studies and frankly, a whole lot of newspaper reports on exactly what you're saying. And I didn't find any well-documented studies that I would say point to your question, but certainly the anecdotal newspaper reports claiming closures of L&D departments, et cetera, really support what you're saying. But I do think that's an area that really could benefit from additional study.
Okay.
Oh, go ahead, Elizabeth. One more question.
Yeah, I appreciate that. So I think it's one of your colleagues who has noted that PE investment is like the divining rod for regulatory failure. And I think that that's where they go. And I'm wondering if there's a way to quantify, PE does what it does. It goes to make money. And if there were downward pressure on prices and therefore profit, would that not be a deterrent to greater mergers and acquisitions? And then using the surprise billing law change as just maybe an example where one of the bigger private equity groups who had invested in all of these for-profit clinics filed for bankruptcy shortly after surprise bills were limited. Is there any evidence there about price controls depressing this trend?
Well, there are really no states with price controls currently. I mean, we could debate whether sort of Rhode Island has them, et cetera. There are some states that have sort of indirect price controls. So I can't really comment with data, although I think that kind of your hunch is right there. I was going to quote the same response to the surprise billing law in terms of the bankruptcy, because I think you're speaking about Aaron Fusay-Brown's work on private equity as a divining rod. I think that's exactly it. I think we could look to places that have gaps in regulation, really, to see where the industry can make money. I also think that one of the big problems with private equity ownership of physicians in particular is that most of them fall below the Hart-Scott-Rodino threshold that I talked about. So many of these are really happening without any oversight. So to the extent that a state wants to shed transparency even in what's happening, that's really the point of that Health, Energy, and Commerce bill I talked about as well, was just sort of understanding who owns physicians and what the motivations behind that might be. I think that could go a long way to both sort of casting a light on these mergers and acquisitions sort of as they're happening, and then also pointing out additional policy interactions, sort of like the ban on surprise bills at the federal level, which actually happened at the state level first. I think it really could identify policy interventions that could be meaningful there.
Thank you.
And Dr. Hernandez, go ahead.
Yeah, thank you for your presentation. Found it very interesting. I'm not familiar with this JAMA article on the PE-owned physician practices, and I'm wondering, is there additional data about what's happening in particular in Southern California as it relates to private equity owning physician practices?
This is a relatively recent article. This was sort of the best sort of evidence that I had, again, because a lot of this is happening kind of without state oversight. Massachusetts does actually have a registry of physician ownership, so there is some data in Massachusetts, although you can see Massachusetts is fairly light colored here on the map. I realize it's kind of small there. You know, I guess most of that is to say I don't really have a good answer because I don't think that it's actually well known among sort of researchers, et cetera. Who sort of owns private equity group, or who owns physician groups?
The follow-up question I have is, are there particular private equity groups who are in this space?
Yes, but again, I think they aren't necessarily all well known. Certainly there are KKR and Blackstone were the emergency room physicians that were sort of a research article that sort of became sort of the basis of the push to get the No Surprises Act passed at the federal level. I think at the individual physician specialty level, there likely are groups there, and I don't think they're as well known, because in one way that this might work is a private equity group could buy all the ophthalmology practices, you know, in a given area. They would be quite small. All the transactions wouldn't necessarily be even reported in the news. So I think the answer to your question is yes, and I would hope that a state might want to shed some light on that would be very, very useful.
Senator Pan.
Yeah, no, again, thank you for the presentation. I guess I think one thing perhaps to look at is the relationship between the corporate bar and the ability of private equity. So they could try to find a quote friendly clinician to be the owner, but I think that there's some challenges there. Not to say that it's not impossible to do that. The other thing, because you talked about the hospital mergers, for example, there have been news stories where, for example, physicians are given metrics for performance. So actually 60 Minutes did an article where I did a piece where ER doctors were literally, as they were discharging patients in the ER, being told, are you sure you want to discharge the patient and not admit them? This is your current admission rate and you are under performance in your admissions. They built that into the EHR so that every physician got a reminder about this is your number, and of course they'd have quarterly meetings on the performance on that, right? So these are metrics that are designed to increase the the admission rates and the revenue that the hospital could generate, from the emergency room. And so I don't know to what degree if people looked into these types of things that may happen when physicians or other providers are actually in employment situations where they actually make decisions about things like admissions and other things that drive the economics of the organization that they're employed by.
I can think of one study. I think a lot of these studies tend to be relatively specific about the specialty. In particular, there was a study of gastroenterologists who then became employed by a hospital. They found that the payment rate for colonoscopies went up about 20%. I could find the notes. And they also did a lot more colonoscopies per physician. And the way that they were able to do this is they put significantly fewer patients under deep sedation, which also decreases the number of anesthesiologists you need per gastroenterologist. And what they found was that it actually caused a big decrease in quality as well. They were having a lot of complications from this. So I would sort of echo what you're saying, because there is this push to physicians, once they have an employer, to want to make money for that employer because their financial interests are aligned. And I think there's a whole lot of studies. I don't want to call them anecdotal because they're very well done studies, but they're kind of a niche, looking very specifically at gastroenterologists or looking very specifically about primary care offering or ordering MRIs, et cetera. But I think that your example is exactly right.
Ian.
No, I think Dr. Panda's example, it really resonates for me because I've seen similar dynamics, not with physicians and actually not with PE-owned entities, but you know, it raises the question for me. I think the physician registry, ownership registry in Massachusetts is interesting, but it seems to me as we go here, we should be building an inventory of tools that we might recommend shed some light on how anti-competitive behavior manifests itself. You know, I understand it operates in the shadows, and shadow pricing is called that for a reason, but I think as we steam forward here, identifying what those tools are that we could recommend to the legislature and or the AG, we would be well served to keep that list.
Well, Katie, thank you.
So I'm going to turn it over to Sheila. I'm just going to advance to her slides.
Can't hear anything.
I'm on now. All right. So as I was saying, this was a really great presentation. Thank you to Katie. I've enjoyed working with her very much over the last 6 months. And it's a great segue into my presentation, where I have the privilege and the pleasure to give you an overview of our cost and market impact review program. So today I'm going to talk to you about basically 5 parts here: the legislative findings, the office's role and responsibilities for the CMIR program, which were very intentional and are consistent with the legislative intent. Then the current oversight in California that we have among our current agencies doing oversight, and then gaps. As you've discussed, we know there are gaps, and we are hoping that our cost and market impact review program will begin to address some of those gaps, and over time really highlight what we're talking about today and to inform the public. So, and then finally, I'll walk you through our timeline for the development of our regulations to implement the program. So this first slide, as I mentioned, the legislative findings, 3 years in the making, very, very intentional about really looking at the impact on cost that consolidation has. So that is the first level there. We know that prices continue to rise, particularly in areas where there is a lack of competition due to consolidation. And so we know that there's a real need to look at consolidation in its various forms. And I want to point out in this slide that, the legislature specifically calls out healthcare service plans, health insurers, hospitals, physician organizations, pharmacy benefit managers, and other healthcare entities. The statute applies to all healthcare entities, but notice that these are repeatedly called out in the statute. In fact, that phrasing appears at least 3 times in the statute. So while it's not exhaustive, it is our starting point, it is our list, it will be our emphasis for our review. And then finally, as we've seen from Dr. Gudison's presentation, market consolidation takes many, many forms and just becomes increasingly creative as there are different ways. As we noticed from her slide, a lot of the horizontal consolidation has already taken place. over the last decade. So now we're seeing more vertical consolidation, cross-market consolidation, private equity. And again, I'm amazed at the creativity and the funding and the various forms. So we hope to get some transparency through our program on these types of different consolidation forms. So here we go again with our list of target entities to look at going through consolidation. So the office's role, which is very consistent with the enabling statute and the legislative intent, is to review consolidation of healthcare entities. And again, I'll call out the list that was repeated through statute. And our review is prospective. So we will be receiving notices of transactions and conducting prospective reviews. And the intent, which is just foundational to OCA, is public transparency. We want to inform the public. We want to track why prices are increasing, why quality can be decreasing, and look at ways that we can inform the public and even receive public comment on those issues. So our office on our program is intended to be supportive of our partners who conduct oversight. So we will be working in a manner that is collaborative, coordinated, and supportive of the Attorney General, the Department of Managed Healthcare, and the Department of Insurance. And we will take a balanced approach. I mean, there is recognition that not all consolidation is bad. I know this today, it seems like everything we're saying about consolidation is bad, but we do want to look at the efficiencies because, our goal is affordability, access, quality, healthcare for everyone. And so it is really important to look at what are the possible benefits of a proposed transaction. We will be seeking input from the public on these transactions. They will be transparent. They will be published on our website. And we intend to collect and report information, again, that's helpful to the public. And finally, we would refer transactions to the Attorney General. They will be working with us closely. And while we do not have the authority to block a transaction, we do have the ability to make our own recommendations regarding conditions and to refer at any time. At any time during our review, we could refer to the Attorney General. So this just gives you a brief overview of the current oversight in California. So the Attorney General, as we know, has the approval authority to block transactions for nonprofit health facilities. And we've seen the recent litigation regarding that. And they do have the authority to investigate other types of transactions by means of the Business and Professions Code 17200. That is the unfair competition law, which they often use to look at other types of healthcare consolidation. The Department of Managed Healthcare has approval authority for what they call major mergers, when healthcare service plans under their jurisdiction are merging, and they evaluate the impact on enrollees and the stability of the healthcare system. And then finally, the Department of Insurance has authority over domestic health insurers, and they review the impact on the marketplace and consumers. So working with those three partners, again, we hope to supplement and support and to look at those gaps that we've started talking about here today. So we've taken a lot of time actually to look at what we think are the gaps in California's market oversight. So we talked a little bit today about physician organizations, and there are a lot of various forms of physician organization acquisitions by health plans, by hospitals. There's quite a movement in acquisition of physician organizations. And so we've also talked about private equity, and that is a growing area, as we know, and we hope that our work will track and trend what's going on in private equity, and again, shed some light for consumers. And we've also talked a little bit, through Katie's presentation about the impact on contracting, whether it's exclusive or whether it's really limiting access. There are a lot of arrangements that come into play where certain entities will go through a transaction that will impact who's actually negotiating for the contracted arrangements, which impacts contracting for physicians, contracting for facilities, contracting for care. So we would be looking at those as well. So this really highlights the 3 stages or steps of our cost and market impact review program. So the first step is to collect the notices of transaction, and the statute requires that healthcare entities provide notice 90 days before the transaction will occur on or after April 1st. And healthcare entities will then undergo a determination that OCA will conduct. We will have 60 days to review the transaction and then determine whether a cost and market impact review is warranted. So this is high level. I'm going to go into each one of these in detail. And I want to also highlight that this slide we have marked as yellow because it is an informational item. As we develop the regulations, those are informational items for the board, discussion items, because the office has the responsibility to adopt the regulation, and it will not be a vote for the board to make at the time we present the regulation. But per statute, our office is required to discuss the regulation at least one board meeting, and we will be discussing it at several board meetings. Let's see if I accidentally skipped one. Went too far. All right, so the notice. So we are developing regulations that will set the requirements for filing notice and the process for filing notice and gearing up our electronic system to collect the notices. So we intend to be ready January 1st because the statute requires 90 days notice before a transaction will occur on April 1st. So if you count back those days, it gives us a start date of January 1st, and we're working very hard to be ready. So once we determine that a preliminary notice of transaction is complete, we would begin the 60-day review. Once we determine that the notice of transaction is complete, we would conduct what we're calling a preliminary review. So the notice has to be complete, meaning that it's not only the general information that we'll be collecting in the notice about the entities and where they provide services and sort of that demographic information. It will be their chance to tell the story about the transaction, but they also have to provide the supporting documentation. And we will not consider a notice complete unless we have all of the supporting documentation. So once the notice is complete, the clock starts. We will begin our 60-day review, and that review is meant to determine whether the transaction needs to undergo a full cost and market impact review. And per statute, you can see it's laid out. If we find that a material change that's been noticed is likely to have a significant risk on the market, the ability to meet cost targets or cost for purchasers, we will conduct a cost and market impact review. And I also want to note that, there's a provision in the statute where the office may conduct a cost and market impact review if the data show, from the cost collection data, that there's an impact on cost, access, or quality. So when we're looking at that spending target data, and when we're down the road years looking at performance on measuring the data, that time we can also conduct a cost and market impact review. And then finally, our sister departments can ask us to conduct a cost and market impact review. For example, the DMHC or CDI could ask us to conduct a cost and market impact review. So again, we are developing our regulations to lay out the factors for what we will consider during that 60-day review and the process. a little bit delay. All right, so once we decide to conduct a full cost and market impact review, the review will look at many factors, and our regulation will lay out the factors in further detail than what's laid out in the statute. But you can see that's what is laid out in the statute is relevant market position of the entities, changes in size, change in control. And change in control is something that that can really impact situations. We talked about the various forms and consolidation, but what we're seeing is that those changes in control are really material because that is what is impacting price, access, care, and quality. So we would look at those things, and we would look at all the impacts on price, access, care, and quality, and we would be looking at the geographic region for these consolidations. And again, our regulation will lay out multiple factors. We also have discretion to look at anything that we think is informative to the public. So we have wide discretion as to what will be reviewed during the cost and market impact review. And as I mentioned, don't want to frame this that all consolidation is bad. We want to look at the benefits because, again, we're interested in the care of Californians. So we'd look at, what benefits could be achieved or might not be achieved without the transaction. And so, again, we want to take a balanced approach. We looked a little bit at Massachusetts earlier with Katie's presentation. They've been doing this for about a decade. And if you'll notice from their website, they've done about nine cost and market impact reviews, which tells you of the volume that they receive over 10 years. They've been fairly judicious about the number of cost and market impact reviews they've done. We, of course, anticipate a larger volume of notices of transactions just based on scale alone. So we will proceed accordingly and take a balanced approach. So in the cost and market impact review, the conclusion of that is to issue a preliminary report. And at the issuance of a preliminary report, the public will have an opportunity to comment and the parties will have an opportunity to comment. We anticipate that these will be written comments and responses, and we will be publishing those again for the purpose of public transparency. Now, a cost and market impact review kind of puts the transaction on hold because they cannot proceed with the transaction until 60 days after OCA has issued its final report. So we issue a preliminary report, receive comment, issue a final report, and the transaction can't proceed until 60 days after that final report. And again, our regulations will further clarify and implement our program. And this is finally our timeline for you on the development of our regulations. We have emergency rulemaking authority, which is a very shortened time frame, but we have, with emergency rulemaking authority, the regulation text goes to the Office of Administrative Law, who has 10 days to review it, and there's a very short comment period. But this was very intentional when we were drafting the legislation, that we wanted to build in plenty of time for public comment, because under emergency regulation, there's only 8 days for public comment, and that for a program like this, that's just not realistic. So we have carefully built in time for public comment on this. So I'll be back in July to update you on our progress. We intend to publish and post on our website the draft text of our regulation. In mid-August, we will hold a workshop on the regulation and anticipate a lot of participation and comment. And we will continue to receive comment until the end of August. And then we'll come back again in August to give you a summary of what happened at the workshop and to discuss the regulation. We'll be revising, as you can imagine. And then September we'll discuss again. And in October, we plan to submit to the Office of Administrative Law. And we've put that October date in there because, again, we need to be ready by January 1st, 2024. Are there any questions?
Okay.
I'll just a comment. One, thank you for both presentations. incredibly important issue. And then just to piggyback on what Ian was saying, you know, anything that we can be doing here to address the challenges that flow from consolidation. Just anecdotally, CalPERS tracks our pricing region by region and then county by county, and we see up to twofold difference in prices, and almost always it is directly related to the competition or the lack of competition in a particular region or county. So if you look at the price differences between Southern California and Northern California, you see this. But then when you go drill down and look at particular areas where there's one hospital or there are two hospitals that are getting along really well together, or medical groups that control pieces of the medical delivery system, prices just jack up. If we are able to address this problem, I don't know that we would need to do anything else. Bringing prices, high prices down to places where there is competition and we see low prices would be a victory in itself.
Thank you. Ian Lewis and then Senator Pan.
Thank you, and I concur. Both these presentations were really helpful and informative, and this is I like this, and you're wise to build in a lot of room for public comment, and I hope that room will persist under the new rules. I'm trying to, in my mind, disentangle the transaction by transaction approach to really building out the inventory of market analysis, given the degree of consolidation that has already happened, and the fact that in light of all that consolidation, any additional consolidation could lead to bad outcomes for us, both cost and access. Monterey jumps to mind, just given the amount of public comment that we've got. Again, don't want to delay this ambitious and necessary timeline, but what's your thinking about really studying the markets and understanding which are most on the precipice or beyond the precipice of consolidation and anti-competitive behavior?
So the hope is, as we roll out this program, you know, our charge is to begin by collecting notices of transactions. And I'd point to Massachusetts because what they're doing when their staff is not doing the review of cost and market impact reports on particular transactions, they then start to do particular studies of either practices or geographic areas. And so 10 years they've been doing this, and you know, we've spoken with them, we've spoken with Oregon, and that was really helpful to us because, you know, in putting together our office, that would be my goal, that, you know, we're going to be hopefully building a rich database of transactions and consolidation, and then we can start tracking and trending and doing some studies on the impact. I hope that answers your question.
Thank you, Senator Pan.
Yeah, no, I really appreciate the presentation. This is vitally important work. Just a couple of comments. First of all, I appreciate the presentation in terms of public input. I know that as the legislation is going through, some anxiety. You know, every time we do something, we say, well, we're going to allow you to do emergency rulemaking, right? That means there's a little bit of trust us. We're actually going to take public comment, right? We're not going to use that as an excuse to just ram something through. So I appreciate that the process you're doing. It's going to be important to get that input. I guess the other thing I would also say is that I know there's and it's challenged. There's a tendency to try to say, we want all the data we can grab hold of, and then we're going to sit there and then sift through all of that and figure out. So, but there's a burden to data submission collection, particularly if you're demanding it of smaller entities, right? So, you know, the entities that are larger with more resources should be the ones that you should be leaned on to get information, and not necessarily always the smaller ones. So hopefully, as you're processing this through, you know, again, vitally important work. We need to have it done, but also that we're having a focus on trying to, you know, not overly administratively burden everyone, right, in the process. And then the other thing I think, sort of respective to what Mr. Lewis brought up, you know, there are certain markets that also, I mean, there's activity, but there's also inherently it's more challenging, right? Part of the challenge with rural communities is that the patient base right, can only support so many providers, and therefore you're going to have a fewer number, right? So consolidation becomes well, first of all, there's a natural consolidation just because you can't have, how many competitors can you have that could actually be financially viable, right? Even if there was no consolidation, how many can you support? And so I think some sort of analysis looking at that's going to be important, and thinking about what are potential alternatives or solutions to that. Maybe not entirely, task of your group, but we need to think about that, right? Because yes, some of it could be because there's actually mergers and consolidations. Some of it could also be because the area is challenged with, the population density and the number of, et cetera. And especially as medicine is getting more sophisticated, and this is what you talked about, the benefit part, right? So, we want integrated systems where we have team-based care, right? It's not like individual providers are going to be able to do everything. So now you need more different people who all work together. And then if you have a small patient base, that's then that team needs a certain minimum patient base in order to sustain it. So we're going to have to figure out how to strike those balances, and hopefully your work will give us some insights into how much of this is consolidation, how much of it is that we have to be a little, more creative and saying, okay, it's going to be hard to get around, perhaps some dominant market players in order to get to that quality integration, but maybe there's some alternative solutions we can think about so it's about quality and not about profit, right? I mean, that's always the struggle, right? Balancing back and forth, right? How much is quality? How much is profit? And so that people actually get the best care at the lowest price. And that value proposition. So appreciate your work on this, and looking forward to the processes we're rolling through here. Thank you.
Thank you.
Other comments for discussion? Yes, Professor Kronig.
Thank you for the really interesting presentation. I'm sure there's a lot of uncertainty, but I'm sure also as you're figuring out about staffing, you must be making some estimates. How many material change transactions, or what's the range of the number of material change transactions that you're planning for?
Well, I see Elizabeth smiling. We've been working with economic experts, and we've been looking with data, with data-informed decisions. And I'm very grateful to the legislature for thinking ahead and planning for staffing. So based on our preliminary thresholds that we will put into regulation, we're anticipating about 100 notices per year, which seems to be about scale, because Massachusetts told us they receive about 4 to 5 per month. So scale that to California, it's conceivable that we could receive up to 100 notices of transaction over a year.
Thank you.
If I'm not mistaken, we're 6 to 7 times as bigger than Massachusetts. So if they're getting 4 to 5 a month, something's not quite adding up to 100 a year, but maybe, we have different thresholds and transactions that are being reviewed by other agencies, presumably don't.
Yes, yes. And remember, Massachusetts only looks at provider transactions. We'll be looking at transactions among many more types of healthcare entities. So.
Comments from those who are online? Board members, Hernandez, Mitchell? None?
I want to appreciate the presentation, and more importantly, appreciate the rapid timeline getting to January. And I think it was a very thoughtful way that the public comment has been inserted into what will be important regulations coming forward. Thank you.
Thank you.
Okay, well, thank you to Sheila. Thank you to Katie for those great presentations. And we'll now go on to invite public comment.
We'll now invite public comment in the room. If you are online, please raise your hand or press *5 if you're calling in. Going to the podium.
Beth Capel here on behalf of Health Access for this item. That was a really excellent presentation on the research. I would only note that most of the studies have data that is 5 to 7 years old, and everything we know says the trends have continued. And so whatever conclusions you may have drawn from the research that was just presented, it's worse than it showed. Secondly, we would encourage, as you move forward, that you coordinate closely with the Attorney General, the Department of Managed Healthcare, and the Department of Insurance We are well familiar with the AG's hospital reviews since we sponsored much of the original legislation as well as the legislation affecting DMHC. And in both the market reviews that you will be undertaking very much complement and strengthen the work that they currently do. Third, we would note that, and we didn't see it in your presentation as thoughtful as it was, the cumulative impact of, I call it the Pac-Man strategy, of big entities gobbling up lots of little ones. We've observed this, for example, with Optum Health in Southern California, which is owned by United Health and which originally acquired a few medical groups. And now there are parts of Southern California where Optum Health is apparently the only non-Kaiser, non-county entity where you can put together a network. So that's a problem. Next, with respect to Dr. Pan's concerns about the burdens on smaller entities, we would note that the law very wisely says it's the acquiring entity, not the entity being acquired, that is required to present to the office and provide all of this information. And that seems to us very important. And finally, with respect to Mr. Lewis's comments and the presentations we've all heard from our friends in Monterey, and sometimes you have to look at material with fresh eyes. On slide 5, a standard presentation I've now seen many times from Mr. Pagani, it says assess market consolidation, but the law actually speaks to market failures, not just to market consolidation. And we think what you've heard described in
10 seconds
in Monterey is in fact a market failure. And wisely, the law gives authority for the director to order a market review in such a situation. Thank you.
Moving to public comment online, seeing no hands raised, going back to the podium.
Hello to the board. Ben Johnson from the California Hospital Association. Appreciate the opportunity to comment here. Hospitals have operated under review from the Attorney General, for example, for a large number of years, and thus have substantial experience that I think that the office can help learn from as it goes forward in promulgating these regulations, including some of the trade-offs that are associated with the review process. These can be slowing down even transactions that are deemed to be in the public benefit and so forth, adding to the costs thereof. And ultimately, where decisions maybe aren't sort of, arrived at with appropriately, can even result in the closure of hospitals, such as in the rural areas, and for hospitals that are maybe in financial distress, and combining and working with other hospitals may be a path towards their continued viability. So we do appreciate the office making a commitment to also evaluating the benefits of proposed transactions in addition to their costs, including the integrated clinical care components that Dr. Pan raised earlier, the scaling that is necessary to take on risk and pursue some of the alternative payment methodologies that the office is ultimately encouraging, and really the sort of preventing those losses of access that can occur when a rural or other provider has to close its door due to market conditions in its area. So we do encourage in presentations going forward, a balanced approach to looking at both these benefits and costs of when conducting these reviews, and just appreciate the opportunity to engage today. Echo Health Access comments to really learn from what has happened at the Attorney General and with our other oversight bodies, make sure that these processes are not duplicative, but are really that they support each other in the office's goals. Thank you.
Moving to virtual public comment, seeing no hands raised, going back to the podium.
Good morning or good afternoon. My name is Hector Flores, and as one of your newly appointed advisory committee members, I thank you for your confidence. I wanted to make a couple of recommendations of something to trend. Dr. Pan, you were astute in your observation about private equity looking at Medicare markets. because they're the low-hanging fruit for immediate profitability, unfortunately. And part of that has to do with the overutilization of Medicare. If you recall, Atul Gawande's New Yorker article in 2009, The Cost Conundrum, looking at fee-for-service abuse in Medicare. The same happens and can happen in other forms, including Medicare Advantage. One of the trends to follow is also physician practice patterns, because the targets for private equity are physicians who are about to retire. And we're looking at the aging workforce, and they're looking at prominent physicians with busy practices and certain specialties. And I think some of you brought that up earlier. You want to look at orthopedics, oncology, anesthesia, emergency room. These are primed for immediate profitability through private equity and other acquirers. Hemodialysis is another one that can be easily abused. So trending Medicare and trending physician practice patterns, particularly those that are retiring. The other part of this is because new physicians are increasingly looking for employed positions. It used to be physicians were considered the last bastion of independence. They're really 70% of new graduates are looking for an employed position, typically in a large organization. So that will also accelerate and continue this genie out of the bottle of consolidation. Dr. Kronik, you asked a question earlier about how does private equity get around the corporate practice bar, and it has to do with finding a friendly physician, a professional corporation that can then practice medicine, or we're also seeing that in hospitals creating medical foundations to do the same. So worth monitoring. Thank you very much for your confidence.
Moving to virtual public comment, seeing no hands raised and no additional public comment in the room. Public comment is closed.
Well, thank you. And we're at the end of our morning session. We now go into our lunch break. So we will reconvene at, let's see, 1:05. 1:05. Thank you all very much. All right, well, welcome back from lunch, and I'd like to call the meeting back to order. Can we please call the roll?
Yes. Mark Galley. David Carlisle.
Present.
Sandra Hernandez.
Here.
Richard Kronik.
Here.
Ian Lewis.
Present.
Elizabeth Mitchell. Attending virtually noted as not yet present. Richard Pan.
Present.
And Don Molds.
Well, we still have a quorum, and we'll continue through our informational items. Next up, we have the OCA Assistant Deputy Director, Margarita Brandt, and we will be taking a break partway through the afternoon, approximately 2:40 during, I think, the midst of one of the presentations. Ms. Brandt.
Thank you, Chair. Good afternoon, members of the board and members of the public. Today, I'll be providing an overview of the work underway for 4 of the 5 focus areas for promoting high-value health system performance, alternative payment models, primary care and behavioral health investment, and workforce stability. So OCA's 5 focus areas for promoting high-value healthcare or high-value health system performance are primary care investment, behavioral health investment, alternative payment model adoption or APM adoption, quality and equity measurement, and workforce stability. And the goal across these 5 areas is to reorient the healthcare system towards greater value with the vision of creating a healthcare system that provides all Californians with high quality, affordable, equitable care. And for each of these areas, I'll provide a summary of the statutory requirements. I'll introduce the evidence briefly. I'll describe similar efforts in other states and then share OCA's proposed approach and preliminary timeline. So today we'll focus on alternative payment model adoption, primary care investment, behavioral health investment, and workforce stability. So 4 of those 5 areas due to the statutory requirements and deadlines associated with those areas. So starting with the statutory requirements for primary care and behavioral health. The statutory requirements here specify 3 components: measuring primary care and behavioral health spend, setting benchmarks for primary care and behavioral health investment as a % of total spending, and promoting improved outcomes for primary care and behavioral health. So turning a bit to the evidence. About 2 years ago, the National Academies of Science, Engineering, Medicine, or NASEM, released a report documenting actions needed to strengthen primary care in the United States. Its recommendations are very well aligned with our work, and specifically it calls for policies that pay for primary care teams to care for people, not for doctors to deliver services, ensure that high quality primary care is available to every individual and family in every community, train primary care teams where people live and work, design information technology that serves the patient, the family, and the interprofessional care team, and lastly, to ensure that high quality primary care is implemented across the United States. The NASEM report specifically notes that implementing high quality primary care begins by a commitment to pay more and differently for primary care services. As noted here, primary care investment in the US lags other high income nations. Spending for primary care in the United States is about 1/3 to 1/2 of other nations, and our outcomes are worse. This report inspired the Milbank Memorial Fund and the Physicians Foundation to work with the Robert Graham Center to develop the first national primary care scorecard, which evaluates the health of primary care, including measuring primary care spending using nationally publicly available data. And although this data isn't perfect, it directionally gives us a better understanding of primary care investment in half the states and nationally. And as you'll note on this slide, the scorecard found that primary care investment in California was higher than the national average, about 6.3% of total spending across all payers, compared to 4.6% nationally. Yet it still lags those international comparisons quite significantly. So looking across the nation over the last several years, a growing number of states have begun efforts to strengthen primary care, specifically through measuring and reporting on investment. More than a dozen states have now measured and reported on primary care spending at least once, though the definitions for how you define primary care can vary. 5 states, Rhode Island, Oklahoma, Oregon, Colorado, and Delaware, now require a defined level of primary care investment for at least one payer type, typically commercial and Medicaid. And as we'll discuss in a minute, measuring spending on behavioral health has become increasingly important to this work and to measuring primary care investment as well. So now turning to behavioral health. For many states, the increasing focus on behavioral health is in part due to how the pandemic of COVID-19 has exacerbated the behavioral health crisis because of social isolation, economic instability, greater acknowledgement of systemic racism, and other factors occurring alongside the pandemic. As noted here, nationally and in California, nearly 1/3 of adults are reporting symptoms of anxiety or depression, and this data is from earlier this year. Unfortunately, we know that too many of these individuals go without treatment. A California Healthcare Foundation analysis from a few years ago found that nearly 2/3 of adults with mental illness in California did not receive treatment. But the good news here is that we know that healthcare delivery models that integrate primary care and behavioral health have been shown to improve access to effective behavioral health services and improve outcomes, as well as deliver a return on investment by reducing downstream healthcare costs. So as I mentioned earlier, several states are starting to measure behavioral health investment, and some states include behavioral health services in their primary care investment definitions. There are 9 states that do so. There are 3 states that also measure behavioral health investment across the full continuum of services. This work is new, just emerging within the last few years. So California can learn on what other states are doing and what definitions they've used. Best practices are emerging regarding the diagnoses, the services, providers to include in the definition of behavioral health, but there's no standard definition. Currently, states measuring behavioral health treat each component of the numerator in different ways. Behavioral health investment varies by the defined list of diagnoses, services, providers, and place of service included in each state's definition. And next, we'll turn to alternative payment models. So starting with the statutory requirements. There are 4 statutory requirements related to alternative payment models. 1, to promote the transition from fee-for-service payments to alternative payment models, measure this movement towards alternative payment models, and set a statewide goal for the adoption of alternative payment models. The goals may be a % of members, providers, and/or payments based on alternative payment models. And 4 is to adopt contracting standards for healthcare entities that encourage multi-payer alignment and promote quality, equity, and efficiency. There are other states across the country who also monitor types of healthcare payment models used by healthcare entities, and we'll talk about this in a bit. So alternative payment models, or value-based payment models, or APMs, incentivize delivering the right care to the right people in the right setting. To do this, payers and providers consider the level of financial accountability that each entity should hold and appropriate incentives for meaningful progress on quality, equity, and efficiency. And APMs include many public and private payment models, and to standardize these models, CMS and other large purchasers, public and private payers, came together to form the Healthcare Payment Learning and Action Network, or HCP-LAN. The HCP-LAN established a framework to categorize alternative payment models based on the level of risk taken by a provider. The framework is often supported by more nuanced subcategories or definitions depending on its use. And so while this framework is used in many other states, it's not the only framework. We have talked about other frameworks used to categorize non-claims-based payments or value-based payments, especially in our conversations around total healthcare expenditures. And OCA is charged with promoting the adoption of APMs due to the recognition that traditional fee-for-service payments are not flexible enough to accommodate innovation in how care is delivered, and that fee-for-service payments really incentivize providers to do more, in most instances, not necessarily to perform better. And the movement towards APMs across the country has been slow. Generally, with fee-for-service making up about 40% of payments from 2017 through 2021 nationally, according to HCP-LAN surveys. In California, with our stronger capitation market, about 36% of members were cared for under fee-for-service arrangements in 2021 in the commercial market. So what's occurring in other states for APMs? In the past few years, the number of states collecting APM has doubled, and their interests vary, and how they collect data varies based on how they defined alternative payment models. Some uses across these states include understanding the non-claims-based component of total cost of care, sometimes with a focus on primary care and behavioral health investment. Similar to California, some states track the movement from fee-for-service towards more alternative payment models. And these experiences in other states highlight the difficulty of understanding how non-claims payments are distributed within provider organizations. So OCA seeks to continue these conversations with stakeholders and gain a greater insight into how dollars are spent by provider organizations who are within alternative payment models. And I wanted to share and recognize that APM's primary care and behavioral health investment are very interconnected, and that's why we're coordinating across these 3 work streams especially. So we know that proactive team-based care and primary care is typically supported by non-claims payments, and this includes integrated behavioral health provided in a primary care setting. And accountability for alternative payment models is often tied to the primary care provider relationship and performance. And as I mentioned earlier, the COVID-19 really highlighted the need for additional behavioral health access across the nation. And many providers during the pandemic and still now increasingly find themselves continuing to fill the gap by supporting patients with acute episodes of anxiety, depression, and other behavioral health outcomes. So in the next few slides, I'll share our proposed approach and preliminary timeline for these 3 work streams: APMs, primary care, and behavioral health. So OCA has contracted with Friedman Healthcare to support these 3 work streams. And for each work stream, the office and Friedman Healthcare will start with brainstorming, conducting research, summarizing current evidence and initiatives related to that area, and then modeling data. And we'll really build on the foundation of collaboration and coordination and alignment in California through the public and private purchase or contract requirements and the California studies on primary care spend. Medi-Cal, Cover California, CalPERS, the Integrated Healthcare Association, and the California Healthcare Foundation, among others, have really paved the way in these areas for California. Over time, we'll develop recommendations with input from stakeholders, refine these recommendations, and work towards finalizing or seeking board approval of the recommendations. And one way that we are seeking input and feedback for these areas is through a stakeholder work group. So we're excited to launch the investment and payment work group to seek stakeholder input on these 3 areas. And our first work group meeting will actually be held tomorrow morning. And the box on the right lists the many perspectives that we are engaging and including in the work group. And the purpose of this work group is to ensure stakeholder engagement in these key program development decisions about definitions and data collection for these 3 areas, to provide input and feedback to the office as we develop recommendations for benchmarks, and to identify and discuss the relationships and interactions between APMs, primary care, and behavioral health. And this next slide provides an examples of the work group discussion topics for each work stream. So across all 3, we will discuss definitions, measurement, and reporting. For example, how do we define behavioral health? What providers are included in the definition, what services, what sites of service, and then how do we collect data to measure and report on behavioral health spending? For the APM workstream, we will also discuss contract standards and the statewide goal for APM adoption. And for primary care and behavioral health investment, we will discuss setting an investment benchmark. And this slide provides a preliminary timeline for these 3 work streams. We will be working towards meeting the statutory deadlines and seeking board approval where needed. In summer 2024, we'll seek board approval of the APM contracting standards, the primary care spending benchmark, and the APM goal. In spring 2025, we'll seek approval of the behavioral health spending benchmark, and we anticipate several discussions with the advisory committee and the board leading up to these dates, supported by the work group starting tomorrow and all the way through 2024 and beyond. And following the board approval of each area, we'll develop regulations, collect and report on data, all leading up to the first annual report in June 2027. So next, we'll turn to healthcare workforce stability. So the statutory requirements for workforce stability specify that OCA will monitor the effects of the spending growth targets on healthcare workforce stability, to monitor workforce stability with the goal that workforce shortages do not undermine healthcare affordability, access, equity, quality, and culturally and linguistically competent care. Third, they'll promote affordability while recognizing the need to maintain and increase a trained supply of healthcare workers. And then fourth, develop standards to advance the healthcare workforce in consultation with the board. And the statute also specifies for healthcare workforce stability that OCA may require a healthcare entity to implement a performance improvement plan to improve spending performance, and that the board approves standards to advance the stability of the healthcare workforce that may apply in the approval of performance improvement plans. We'll be focusing on the approach and the timeline for the general standards to advance the stability of the healthcare workforce, not the standards used in a performance improvement plan today, due to the statutory requirement to develop those general standards on or before July 2024. So for workforce stability, California currently faces a significant healthcare workforce shortage, including an imbalanced geographic distribution of healthcare workers as recognized by the California Future Health Workforce Commission and other programs to monitor and strengthen the healthcare workforce, including HCI's own workforce programs. The health workforce challenges really contribute to lack of access to needed services, including preventive services, delays in receiving appropriate care, and preventable hospitalizations. As the Health Affairs Council on Healthcare Spending and Value noted, efforts to slow spending growth may have unintended consequences if healthcare entities reduce labor costs through staffing reductions. And we know that a stable, well-prepared, and adequately supplied workforce is essential to a sustainable healthcare system that provides high-quality, equitable care to all Californians. And to date, no other state has included workforce stability standards in their spending growth target efforts. However, we're really interested in learning how these states with spending growth targets programs have been thinking about workforce stability as they implement their targets, as they may have lessons learned or insights to share. So I don't have a map to show you for this area, but we're really interested in engaging the other states for workforce stability. And to support the workforce stability standards, the office has contracted with the Institute for Health Policy Studies and the Health Force Center at the University of California, San Francisco. And this slide provides a preliminary timeline for this work stream. Somewhat similar to APM's primary care and behavioral health, we'll start with brainstorming, conducting research, and summarizing current evidence and initiatives related to workforce stability. And throughout 2023, we'll focus on research and stakeholder interviews and developing those draft workforce stability standards. By summer 2024, we'll develop standards in consultation with the board, and we anticipate several discussions again with the advisory committee and the board leading up to summer 2024. And then again, following board consultation, we'll conduct data analysis to support the implementation of those standards. And with that, I'm happy to answer any questions the board may have. Thank you very much.
Well, thank you, Assistant Deputy Director Brandt, and we'll go on and take comments and discussion. Senator Pan.
Thank you so much for that presentation. And really appreciate the look at alternative payment models. You talk about how APM's primary care and behavioral health are interconnected. I think one of the things, and I'm a big supporter of alternative payment models, but also I think we need to think about where they fit best and so forth. So for example, one could argue that certain types of preventative care, right, actually a fee-for-service model may actually work very well, because you literally, this is the guideline. As long as you give the vaccines at a particular time, it's not a risk-bearing thing, right? So I think that's what it perhaps best fits in, for example, chronic disease management, which, by the way, most mental health is essentially, it's kind of chronic management, right? Unfortunately, we don't have very many immediate cures for mental health conditions. So in that space, which, by the way, it's where we spend most of our money on anyway, right? So if you look at people, chronic conditions is probably about 80% of our healthcare spend. So I think that so certainly APMs have an important role. One of the things is that as we're looking at models of primary care, if you look at Barbara Starfield's work on primary care, the thing that really makes the difference that oftentimes people overlook is the relationship between the physician and the patient. right? And so every time we have a disruption in that, and you hear this all the time, like when we do chronic care visits, so people have developed a care system, and when it gets disrupted, right? Because if we think about people as basically widgets where, oh, well, your primary care doctor doesn't matter who you see, right? That they get an ongoing relationship, then you build trust. Trust then leads to greater adherence to treatment plans, et cetera. So that's all tied together. So somewhere as we're looking at this, I think oftentimes we overlook those relationships, and those relationships have value, and they lead to lower spend, lower utilization, all those, that's Barbara Starfield's work, all those positive things that come out of primary care. So I mean, it's not just about, well, we should spend more on primary care. Hey, and I'm a primary care doctor, so full disclosure, hey, that sounds good to me. And there's actually a lot of infrastructure. It's not just like we need to pay primary care doctors. There's a lot of infrastructure around. But we also need to think about how do we value things like continuity, right? That relationship, right? So if you have a chronic condition, a mental health condition, other chronic conditions, the fact that you have to go and retell your story every year or however months to a new person who has no idea, they're looking through their past chart and stuff, but so somewhere we've got to figure out how to capture that in this APM model, whatever. So I know we're kind of up here and some of this is happening down here. We got to figure out how to make those incentives work so that we're not just looking at healthcare providers as essentially interchangeable widgets. It doesn't work that way, and we paid a price for that actually in both cost and lower quality. So I just want to emphasize when we look at advanced primary care to be sure we have the actual elements of advanced primary care in there, not simply a financial one, not tick the box off. Okay, here's the NCQA boxes, tick, 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 right? But that we're incentivizing the types of behaviors that lead to the kind of outcomes that we want. Thanks.
Other comments, Mr. Lewis?
Thank you. I'm glad this presentation is following the last one. I mean, the contrast couldn't be starker, and these two, primary care and behavioral health, intertwined, are case studies to me in market failure. I think when we use the term workforce, we should be very precise about what we mean by that. It's a workforce that is participating in the formal financing mechanism of our health system. And I think for all the good workforce development work that our state is doing and billions of dollars that we're putting into it, we're at risk of pouring water through a sieve to the degree that the workforce, however many more we add in at the front end, we're losing just as many at the back end. In the case of behavioral health to cash-based transactions. In case of primary care, I'm less expert, but I imagine the differential between primary care and specialist reimbursement has not a small part to do with that. So I think a couple thoughts flowing from that. One, with regard to the benchmarks, I think we should keep an eye out to not just using a percentage of total spend as a benchmark, but also relative pay, primary to specialists or behavioral health. It gets more complex when you're, but comparing what payers are paying comparable licensures between the behavioral health and medical divide. And likewise with the analysis that HealthForce and others are doing, I know HealthForce did one of the handful of studies that has been done on behavioral health. The LAO has done a literature survey as well. None of these studies have been grounded in labor economics, and in this context, the driving force of market failure is labor economics. And I think we need to make sure that that's a core piece of any analysis that's being done. And lastly, to the question of APMs, I mean, arguably California has been the laboratory for APMs for many decades, and in many regards with mixed results. With regards to consumer affordability, I think the verdict's clear. So I think, I worry that other states are looking right now to replicate what California has already experimented with, and I would really look to this work to see, what is what actually results in quality care and access, and addresses those workforce imbalances.
Thank you. Other comments or questions? Yes. Elizabeth,
Thank you.
personally.
This Elizabeth? Thank you. I wanted to just add a few comments on the payment reform piece. I actually served on the land for about 8 years and co-chaired PTAC on payment models. So I think it's really important to track the outcomes in terms of total cost and patient outcomes, in addition to sort of payment model adoption, which is just secondary. And I think I said this at the land multiple times. It's not enough to just adopt new payment models. Really tracking their impact on patients and spending is the point. Another challenge that I anticipate is it is very hard to get the commercial plans to share this data. We actually collect it on behalf of our employer members, and the commercial data aligns that investment in primary care is actually decreasing as a percentage of spend. But I think it is going to be challenging to sort of get some of that data, and we're happy to help in any way. And then finally, just thinking about equity and how that should be considered in the payment models. I hope that's on the radar screen.
And also online, we have Dr. Hernandez.
Thank you, David. Yeah, I want to add just a few comments here. One, of course, CHCF has been very interested in behavioral health, primary care integration, and done a tremendous amount of work in the behavioral health space. And I would argue probably the place where it will be hardest to get data, precisely because there's such a cottage industry of where so much of behavioral health, not county, I'm not talking about county specialty care, but really other behavioral health capabilities that we have in the state. And so sort of thinking about how we get at that information and that data seems to me to be a really important part of this work. Super supportive of it. I also just wanted to add on to Ian's comment on labor economics and how important that will be. We're really cutting new ground here on workforce stability, defining it. What does it look like? Because I think part of this is what's the nature of the workforce that we actually need in order to get the kinds of primary care outcomes we're seeking and outcomes in general. So really getting at an understanding of what stability means in terms of what kind of workforce we need on these teams seems to be a very important part of this work. I'm delighted you're working with Workforce. I think they'll be a great partner on it. So I'm very excited about all of this effort and stand ready to support it in any way I can. Thank you, David.
Thank you. Rick Kronik.
Thank you, David, and thank you for that excellent presentation. A couple of comments and then one actual question. On the comments, I agree wholeheartedly with Ian about the importance of gathering information on things other than just primary care spend as a fraction of total spend. And Ian's labor economics comments, sort of health policy folks have argued for years that Medicare undervalues primary care, that problems with the RUC process and RBRVS were, RBRVS was supposed to sort of fix this and didn't much. And CMS has made a little bit of progress on increasing relative payments on for primary care, and as well as introduce some chronic care management payments. And then it's striking that in the commercial world, the best data that we've got, and as folks have said, the data are not great, commercial payments for primary care appear to be fairly close to Medicare's, maybe 105%, but probably somewhere around 100%. And commercial payments for specialty services are, we think, averaging 140 to 150% of Medicare, and for some specialists, much greater than that. So we think, many people think Medicare undervalues primary care, but to the extent that there is some market out there, the commercial side is even worse. We saw in the earlier presentation that the concentration of primary care, the HHI index, is much lower than for specialists, and that may be, it probably is an important part, although I think that we don't have evidence directly connecting kind of why do commercial payers pay specialists on average 140 to 150% of Medicare, but for primary care only 100%, at the same time that we think we have a shortage of primary care physicians. So what's that about? And I think emphasizes the importance of the comments that Sandra made about paying attention to the composition of primary care teams that will work, because we're not going to solve that anytime soon, and we're going to need to make use of nurse practitioners and physician assistants in greater ways than we have to date. My question is about your timeline slide, and if you could
For
the one
alternative.
the one before this.
Okay.
Yeah,
Oops.
that one. So we're in the summer of 2024, the board will be asked to set primary care and APM benchmarks, in the spring of 25, a behavioral health benchmark. But the data collection on primary care doesn't look like it's starting until the fall of 25. And I can imagine maybe setting a benchmark that says primary care spending should be 20% more than it is now, or the difference between primary care and specialist income should be 20% lower than it is now. That's kind of a weird benchmark. But it is hard to imagine, without having the data on what the status quo is, what benchmarks we might be able to set. And so I wonder what your thinking is about what those benchmarks might or could look like in the absence of having collected data.
Sure. So we will hope to be and plan to use current data in California. There have been California studies on primary care investment. So using that information, both in the commercial market and in the Medi-Cal market. We also aim to look at the evidence in other states, the benchmarks that they have set, and how those might, potentially interact with California's potential benchmark. And then we'll also hope to be looking to analyze early data that we might be getting either through the healthcare payments database or through the THCE data collection, the total healthcare expenditure data collection. So we're hopeful that we can analyze some early data, but if not, we may look to past studies in California.
And Rick, I'll just follow up on your comment by saying that in under-resourced areas, these payment disparities are even greater because so much of the population is actually reimbursed through Medicaid and Medi-Cal, and those rates just amplify the ratios that you're talking about. I think Elizabeth has her hand up again. Elizabeth?
Yeah, sorry, just one last thing. Will you be also looking at some of the regulatory barriers to alternative payment model adoption, like DMHC creating some barriers to moving to more capitated models?
I think that's a possibility. We could look at that in the standards, but I'll turn Michelle and Elizabeth.
So OCA will definitely, look at barriers, but in terms of changing them, that's up to policymakers. The statute for OCA does have the ability for this board to consider, any statutory changes or propose statutory changes, not just for APMs, but various activities in the healthcare system. But we are also closely working with our sibling departments as well on kind of, what could be done within the existing California policy framework.
Okay.
Dr. Pan?
Thank you. Yeah, So first of all, another person to agree with Ian's remark about labor economics, right? So I do a lot of workforce research. A lot of times people focus on the front end, like how many people are pumping into the system, but actually we have a lot of people leaving for lots of different reasons. I've been talking to nursing workforce experts, and they say, you know, basically the nursing shortage is actually people, I mean, not, there may not be enough people coming in, but there's also mainly because people are leaving, right? And they're leaving early. And that's due to moral injury, lots of other, you know, work environment, things like that. So I think we need to, as we're looking at the workforce. By the way, I'd also mention is that research has, studies have shown that primary care doctors only spend approximately 28% of their time actually doing clinical work. Like we could double our primary care workforce by simply decreasing the administrative burden to less than 50%. We can almost double our primary care workforce like that without having to train another person, because that's where they're spending your time doing documentation, EHR, billing, you know, prior authorization, all that other junk, frankly, the stuff that patients don't want. Patients would prefer them spending time with them. So, so we need to really think about that too when it comes to bumping. So I guess the question I have is, and you're going to be collecting data, but if we're setting these benchmarks and we're saying, let's increase our primary care spend, and I'm all for that, it'd be good to know exactly where that money is going. Is it really boosting primary care capacity, or is it going to more administrative overhead time, right? Because more burdens being placed on primary care physicians, actually all physicians and other healthcare providers, but to do more documentation, to do more prior auth, waiting on phones, getting approvals, stuff like that.
Sure. I think we could probably look at that in a few ways, although it might be challenging to get at exactly in terms of how we define primary care. What is the definition? How are we coming to that numerator of primary care spending compared to total spending? We could also look at, through the APM contracting standards, are there ways for us to look at reducing administrative burden on providers, especially primary care providers? And I'm sure there are other ways we can look at this as well. Thank you.
Other comments or questions? Margarita, thank you very much. We now invite public comment.
Moving to the room.
Beth Capel here on behalf of Health Access. To step back even further, on primary care and behavioral health and alternative payment models, I think the vision of those of us who helped to construct the original proposal was that it would take easily a decade for this experiment to pay off, and that we hoped you would approach it both in an iterative manner, which I think some of the comments indicate you're going to need to, and also that you would accept, and this is a hard thing to say in a public policy setting, that it is in fact an experiment, that some things will work and some things will not, and some things will work better than other things. And I think when we look at, things like accountable care organizations and the history in California of risk, that is also true. One important consideration as the work moves forward on the alternative payment models, and this is one where perhaps we differ with our friends at PBGH, taking risk always should involve having reserves and capacity to meet that risk. From a consumer perspective, the bankruptcy of medical groups in the 1990s, the occasional bankruptcy of health plans is a terrible tragedy, as it was for the providers who were involved. And so while we've strongly supported the discussion about alternative payment models, for us it goes hand in hand with taking risk, goes hand in hand with having the capacity to manage that risk, including through financial reserves. We are participating in the primary care and behavioral health work group, which now has a different name that I can't remember. But we are looking forward to that discussion and to the work evolving over the next many years. So thank you.
Looking virtually for public comment, reminding folks attending virtually to raise your hand, or if you're calling in, to press *5. Seeing none at this point, going back into the room at the podium.
Hello again, Hector Flores. Thank you, Margarita, for your presentation. I think it really kicks off a very important series of thinkings. The comment I would have as you continue your work is to know that alternative payment without practice transformation is like buying a car without an engine. We really need to make sure that we transform practices to that team-based model that Dr. Pan was talking about and the outcomes that Elizabeth Mitchell was asking for. We cannot just create a windfall for physicians or other practitioners, providers, without that accountability. But there's a great opportunity I did want to highlight that your board should consider tracking, and that is the Governor's Health Equity and Practice Transformation Fund. It is a historic investment in achieving that transformation. And here I want to thank Dr. Sandra Hernandez, not because you're on the board, but because California Healthcare Foundation funded a pilot program with LA Care called Equip LA, which is Equity and Quality and Independent Practices Los Angeles, to begin understanding what that transformation entails, how much it costs, and what should be the metrics and milestones we use to achieve it, to measure its success. The other part, in terms of important benchmarks, I would recommend that you invite Kaiser Permanente to talk about how they envision their primary care to specialty workforce. I trained at Kaiser, and I was impressed by how much they invested in primary care, including developing their own residency programs. And their spend, reports I've seen outside of Kaiser's, that's 16% on primary care when you include the pension plans. But it is really important to look at labor in general, because as we heard earlier, from Margarita, when corporations try to save money, the immediate thing they start to do is cut FTEs. And they always talk about right-sizing, but somehow it always results in downsizing. And it's really unfortunate for those individuals, but the people they serve, because the quality certainly goes down. So in addition to looking at benchmarks for organizations like Kaiser, is to listen to reports from labor, the front line that they represent, and the less organized but informal employee coalitions that are also forming, that are seeing and viewing from the level of the street where the consumers are. Thank you.
Looking back virtually for public comment, seeing no hands raised, going back to the podium.
Joan Allen, SEIU United Healthcare Workers, and specifically on the healthcare workforce piece, could not have asked for a better tee up. Wanted to first appreciate that the timeline on the healthcare workforce piece is moving about as quickly as we could ask for, and looking forward to engaging around those standards and around those benchmarks. Do want to encourage that as we talk about workforce, we talk beyond just the physician and physician extender workforce, to also remember that there is the entire rest of the healthcare workforce continuum, where we are in a workforce crisis and have been for several years, a crisis that has been exacerbated by the last few years of real struggles. And that if we are not focusing on the healthcare pipeline as part of that stability, that we really are setting ourselves up for an even more acute problem down the road. And so encouraging creative solutions for how we solidify that workforce, not just now, but toward the future. And remember that as we see those cuts, as we see those FTEs cut, that is just setting us up for failure. We've seen examples here in California just within the last year of hospitals and other entities who have short-staffed as much as they could, and then when there's a problem, they don't have the money to then go out onto the market and find travel staff. And so what looks like a cost containment effort at the start then leads to a catastrophic workforce failure.
10 seconds.
And so it encouraged us to take that more holistic approach to the workforce standards and benchmarks. Thank you.
Looking back virtually for any raised hands, seeing none. Give it a moment. Seeing no one at the podium in the room. That concludes public comment for this item.
Well, thank you. We will now turn to agenda item 5C, which is total healthcare expenditures. We'll devote the rest of the afternoon to this presentation. I'll turn things over to Deputy Director Pegany, but before doing so, I'll note for Michael Balick's point, we will be taking a break probably half an hour or so into your presentation, about 2:30 or so. Deputy Director.
So before we hand it off to Michael, just want to give a note regarding the organization of the presentation. So similar to last time, Michael will be at the beginning giving a recap of what we discussed last time, and then as we get into new topics, going over the background, lessons from other states, any other considerations, and then he'll turn it over to me to cover the proposed or planned OCA approach. And please proceed, Michael.
Great, thanks. Good afternoon, everyone.
Good afternoon.
Nice to be with you. So before we launch into the slides, I just want to remind you of our acronyms. So total healthcare expenditures, that's THCE, just as a reminder. That's spending on healthcare plus private insurer administrative costs and margin. Total medical expense, TME, is just the healthcare payments part, does not include insurer admin and profit. It's just a little reminder since we haven't used that terms for a while. Okay, so I want to give a brief recap. During our last meeting, we touched on 3 topics. We talked about reporting THCE and TME, including levels of reporting, state, market, payer, and provider entity. We talked about possible regional definitions for measuring and reporting. We talked about service category analysis. The second topic was we talked a little bit about reporting at the large provider entity level and how best to do that. And then we just started to talk about risk adjustment methodologies as a subset of a broader category of spending target program adjustments when doing analysis and reporting. And so for today, we're going to focus just on this adjustments topic. We're going to start with risk adjustment. So I'm going to pick up, actually, I'm going to go back and review what we talked about last time, and then we will bring that conversation to a close. And then we'll talk about other ways of performing adjustments when measuring spending target performance. Any questions? Okay. All right, so I shared this slide last time. As a reminder, for baseline reporting, which is what we are focused on right now, the reporting will only include risk adjustment. The statute requires it to do so, so we'll talk about that further today. But then there are 4 additional types of adjustments, some required, some discretionary, that are also identified in the statute. I will note that I'm going to go through all 4 of those and what the statute says about them. Sometimes it specifically says the target shall be adjusted. Sometimes it just says there shall be adjustment, which could mean that performance is adjusted. Sometimes it's a decision the board makes. Sometimes it's a decision that the agency makes. So just the way it was drafted. I will let you know that of those 4, equity, quality, organized labor, and Medi-Cal, that none of the other spending target states make any adjustments for any of those 4. Okay, so risk adjustment. As a reminder, the statute says that the board, in consultation with the board, the office shall establish risk adjustment methodologies. So this is an office decision. It does provide some detail here that gets into some of the methodological issues we talked about last time. It says shall rely upon existing methodologies, that shall take into account the impact of perverse incentives. And so specifically identifies that there are complexities to doing risk adjustment and that should be considered. Also, as a reminder, risk adjustment, sometimes called health status adjustment, sometimes called, well, I'll just leave it at that. Risk adjustment or health status adjustment is where a modification is made to a measurement of, it can be payment, it can be quality or some other type of performance by developing a risk score and adjusting the performance measure by the risk score. In the case of risk adjustment for a spending target, we're adjusting for the composition of the patient population or the member population, and really how that population changed from the prior year to the performance year. Okay, we're not comparing population of health plan A to health plan B or provider entity A to provider entity B in terms of whether one is serving a sicker population or not. We're just trying to assess, when we're evaluating spending growth, did the population change in a way that would impact the spending? Okay. This is normally done using administrative data, claims data, and the risk scores adjust the expected dollar amount. So most of this is done using claims and diagnoses. We talked about this last time. Because you are using claims with diagnoses on them, whether or not someone accesses care is going to influence what the risk score is. And so people who do not access care will appear to be healthier than people who access care more often, despite the fact that the health status may be the same across the populations. So that's a big concern. There's an equity implication there, and evidence through research of the equity implication. The second concern with diagnosis-based risk adjustment is it's heavily influenced by coding practices on claims. And there's lots of evidence, lots and lots of evidence on coding practices influencing risk scores. There's also evidence from states with spending targets. So Massachusetts studied rising risk scores. They could find no way to verify them when they looked at independent data. So for example, for hospital case mix scores, they can graph a fast rising line, yet when they look at average length of stay or ICU utilization, they're flat. So they weren't able to verify it. So the Massachusetts Health Policy Commission now recommends making no adjustment when they assess performance against their spending target. You know what it says? Recommends. So the reason for that is Massachusetts has their methodology in statute, which means their hands are proverbially tied behind their back. So they can only change their methodology if their legislature changes the law. In Rhode Island, in the first year of their spending target, which was 2019, payer risk scores grew 4.6% in 1 year. And the effect of that was it essentially raised their spending target from 3.2% to 6.4%. That was the effective impact of the rise. And so they moved away from clinical risk adjustment after 1 year, and they moved to age-sex adjustment. And then New Jersey, Oregon, Rhode Island, Washington are now using age-sex. Nevada's governing body recommended no risk adjustment akin to Massachusetts. Okay, so I went ahead too far. So I've talked about clinical risk adjustment. Actually, I've talked about all of its ills. There are some strengths to it. It explains a lot of variation. It explains about 50% of variation, which is a lot. So it's hard to throw it away. At least the Society of Actuaries says that. I saw Rick's furrowed brow, and I knew I was in trouble. The Society of Actuaries says that. With truncation, even better. Okay. So you give something away when you do not do clinical risk adjustment. So I want to acknowledge that. The other option that I referenced from some of the other states are age sex factors. So age sex adjustment acknowledges that spending patterns vary by the age and or sex of an individual. We know, for example, as people get older, their burden of illness increases and their healthcare spending goes up. We know that women of childbearing age have higher spending than men of the same age. So this is a really simple approach that says we know relative to one another that these different age sex cells are going to spend more or less. And so all these weights are relative relationships to the relative relationship to the total population spend. And these weights can be established a priori and given to the payers and told and tell them by market, here are the weights you should use. Or you can collect data in age sex cells from the payers and calculate using their aggregated data what the cell should be. Okay, those are both possible methods. So this is a very small font, advantages, disadvantages table of clinical risk adjustment and age sex risk adjustment. I will, I think I've noted as the advantages for clinical, it explains variation and can ensure that if an organization's population does change, and I'll note that no states do age sex adjustment at the state level or at the market level because the populations are huge and you're just not going to see changes in the course of the year. But if you're looking at a provider organization that's not very large, well, let's say they have a really large employer group that's all people in their 50s and 60s leave them one year, and that was, say, 20% of their patient population. This is fictitious, obviously. But if they leave, then that's going to bring the health status of their population way down. And so one of the reasons that we're doing this is to account for those changes in the population between years. So clinical risk adjustment will do that, because if you know that you've got, or actually I shouldn't say a group like that. Here's a real life example. A Medicaid ACO in another state had an arrangement where in a large city they were serving all of the Medicaid beneficiaries with serious mental illness. And the state moved away and said, we're going to spread that volume across all of the ACOs. Well, when that happened, that changed the health status of that one ACO a ton, and to a lesser degree, all the others. So clinical risk adjustment, if it's a good clinical risk grouper and can pick up serious mental illness well, is going to capture that. So that's an advantage. The disadvantages I've talked about. It's based on access to services. So if you have populations not receiving care, they're going to appear to be healthier. Coding. It's possible you're going to penalize organizations that do a better job of serving sick patients because they're going to show up less often and they're going to have fewer diagnoses on their claims because their conditions are being managed and they don't develop additional comorbidities. Okay. And then finally, with clinical risk adjustment, the challenge here is that every insurer licenses a different grouper or a different version of a different grouper. And so you've got to find some way to get them all to use the same software. And that is not a small logistical challenge. Okay. Age sex. So age sex captures incremental aging of the population. And in the course of 1 year, aging of the population is probably likely to be the biggest impact on change, unless you have populations that are moving around the way that I gave you that example for that Medicaid provider. The other strengths, it standardizes risk adjustment because everybody's using the same weights. There's no gaming based on claims. You don't have to worry about that. And there are no biases due to differential utilization patterns. The downside is that case that I gave you of the ACO with all of the members with, or patients with serious mental illness, it wouldn't capture that at all. That would be totally missed. And any other substantive changes in health status through shifts of membership wouldn't be picked up. Shaw.
So as far as OCA's approach, we would risk adjust for age sex factors only to capture the impact of an incrementally aging population and avoid the distortion associated with coding practices.
Oh, I want to add something I forgot. Rick, at the last meeting, you said, well, you could look at Medi-Cal disability eligibility status. You remember that?
Yeah. Medi-Cal and Medicare, actually.
And Medicare, right,
Yeah.
right.
Yeah.
So that is obviously theoretically possible, but you'd have to develop a methodology for doing that. I mean,
pretty straightforward.
Yeah.
It's sort of age sex data. You're going to need to
right,
develop weights.
right. You'd have to develop weights.
Weights for
Right,
Medi-Cal and Medicaid.
right. So you could do that,
disabled, yeah.
but only for Medicare and Medicaid and only for disability status.
Right.
Yeah.
But it actually might capture some of your ACO, Medicaid ACO example.
Yeah.
To the extent that those patients were on Medicaid because of disability, which if they had severe mental illness, they might well have been, you might have seen a change then in the distribution across provider groups or across payers of the number of people on
Right.
Medicaid with disabilities. So
Right.
you might get some of that.
Right, right. Yeah.
And there's some loading issues with this slide. So the second bullet listed here, so OCA would establish a reporting mechanism where age and sex data and its relative weighting would be specified to payers for uniform application. And then within a market that is commercial, Medi-Cal, and Medicare.
Before we move on, I think Senator Pan has a question.
Yeah, and so I guess one of the questions I have is that when you say age, sex, and you certainly capture the aging population ages, and we know California's population is aging on average, like the rest of the country. When you have a large scale event, well, I mean, we just came out of one, COVID, right? And we were estimating approximately, I mean, there's various, but people are talking 10%, 20% of people with long COVID. That's a discontinuity from pre-COVID, right, which was 2020. So how are we going to incorporate that? Because that's going to drive up healthcare utilization, right? I mean, this is a whole new population of folks. You know, HIV, same thing, although probably not the same scale as COVID, right? So you know, if we're just taking a trend line age, sex, and we just move it forward, and we don't capture these large events that have, you know, that cut across the population. Or if if we had some, sudden treatment for Alzheimer's or diabetes or something that's a fairly, common chronic disease, we're going to have a problem where there's a distortion where either we deny people access to that treatment or that diagnosis or et cetera. So what's going to happen to all the people on long COVID if we just do this, right? Are we just going to say, well, you don't really exist. We're just going to cap it down. We don't exist. So can you address that particular issue? We've just come out of large scale health event, which is still going on. I mean, people are still dying of COVID. People are still getting disabled with COVID, and a large percentage of the population is being affected, even if they're not even actively infected right now, right? So how's that get factored into this? And so this is, by the way, this is not even just individual, assuming we're first talking about just for the so-called total health expenditure piece, right? In terms of what the trend line should be. But then we can start delving into as we're talking about, within different, if we're starting to compare different entities and so forth, which is a whole nother issue. But so how are we going to address that particular, that issue?
I was just going to, the first targets for 2025. So to some extent, that would be in the baseline of the population in terms of their utilization.
Well, I mean, Maybe. I mean, it depends on exactly. I'd want to see how you're leading up and how you're incorporating that. So you're gonna have a line that does this and then this, right? Beyond age and sex, right? And I think we're just trying to get our arms around long COVID right now. So, and exactly how much that will cost and the level of disability and so forth, right? So, and it's now 2023 and we still don't got our arms around it. So I think we have to create some space to include that. And so that's why I'm just concerned about, exactly what that adjustment should be. I don't know. In fact, we might not be able to figure that out right away, but if we do just a strict age sex factor, we're not going to build that in. So that's what I'm saying. We have to create some space for those types of events, which would say we're just coming out of, well, we can argue whether we're out of it or not, but, so it's not just the acute, we're out sort of the acute part where people were dying in hospitals and we had morgues, not enough, being tractor trailers parked outside of morgues because there's no room to bury everyone, et cetera. But we're now in the chronic, we're now moving into the chronic disease part of it, the long COVID, et cetera. Studies are coming out, et cetera. So, so there's going to be a bit of a discontinuity there. And hopefully by 2025, depending on how recent the data you are, to do the adjustment, right? What span of time you're incorporating and how you're building that in, it may or may not be built into it. So if if you're catching that upturn, that maybe you will, but we have to be sure that that's happening, right? So so I think we just got we got to create some space to factor that in beyond just the current age sex paradigm for risk adjustment.
I guess I would say to that is kind of beyond the impacts of COVID, there's other, like you mentioned, medications and other things. So kind of the purpose of this risk adjustment would be to remove the biases due to coding practices and other factors. But on the back end, when an healthcare entity is evaluated against a spending target, as part of the progressive enforcement process, we would look at other factors for why they exceeded the spending.
Well, this is across the board. This is not the specific entity, right? Now, different entities may operate in different ways in response to that, right? I could try to avoid people with long COVID, right, et cetera. I mean, but so as we're looking at doing risk adjustment, I think, for example, if we're trying to capture the level of disability, that might be a way, right? So we have an increased number of people with disability we're picking up in Medicaid, et cetera. That's a sample, maybe that gets incorporated, but I think we just got to create a space for doing this for large scale events, right? So that's a little different than the entity by entity behavior, right? But it's not simply like, oh, well, we have age, sex, and healthcare stays static, and so therefore, just between that stays the same for every age, sex combination, right? So as long as we age for age, sex, everything's fine. We actually have a change in the overall trajectory in terms of level of disability, potentially.
So I think we can look at the experience of other states in this because they've had to deal with this. So, for example, I might have shared this before, early in Massachusetts, in their experience, Sovaldi came out. And there was a huge spike of spending because everyone with hepatitis C went on Sovaldi in the state. And they acknowledged that, and they said, okay, we have a quirky year this year, and we're able to isolate the impact, and so we understand that. But far more dramatically is what just happened in 2020 and 2021. So in 2020, trend was negative in all the other states. Now, it wasn't really negative, but all the federal dollars that went out weren't captured. So it appeared as if it was negative. And what happened in 2021? The trends were crazy high. And so every single state said, we know what this is. This is the rebound from depressed spending in 2020 and depressed utilization. And so we're not going to hold anybody accountable for exceeding the target in that 1 year because we know exactly what happened. We had an aberrant event, and so we're going to recognize that. So I think that's what you will always have to do if there is a big event as you.
Okay, yeah, so I would just argue that we should explicitly say that it's not just age, sex, right? And that we have to take account. And my concern with long COVID is that it's not it's an ongoing issue. Now, maybe we'll develop a cure for that or something, but that's an ongoing burden, right? Unless you develop a cure. I mean, the good news.
Well,
about
but I would say,
yeah.
So is growing obesity and growing rates of diabetes.
Well, yeah, exactly. Well,
Right.
I would point out
And
that is exactly the point.
And in the other direction, declining rates of tobacco consumption.
Right.
There are all kinds of things that are sort of changing over time that affect.
So that's risk adjustment. That's what I'm saying. Risk adjustment beyond age and sex, both ways.
The legislation asks us to set a spending target. And I think our ability to adjust that spending target for changes in the healthcare needs of the population, we don't have the technology to do that in a reliable way beyond the simple things that we can measure, like age and gender and disability status. It'd be nice to think that we could do that with diagnostic information, but the quality of our diagnostic information is so poor. If you take a group of people who are coded with quadriplegia this year in the Medicare world, 40% of them don't have quadriplegia show up on any healthcare claim next year. I doubt they've been cured, but the physician doesn't get paid for writing down quadriplegia, that doesn't get written down. And I think any attempt to use diagnostic information in a formulaic way to adjust these targets will lead to madness and worse outcomes. We always, as Michael said, as a board, would have the possibility in any given year to say, you know what, something really weird has happened and we need to make an adjustment. But I think it makes sense to leave that as an ad hoc possibility rather than try to build it in a formulaic way.
So I don't disagree with that. Then we should acknowledge that we said risk adjustment. So risk adjustment would include adjusting age and sex, and for the board to also acknowledge large-scale events, right? It's not formulaic. It's going to be a little bit on our judgment, but we need to acknowledge they happen and that there are trends that happen. And we may not have perfect data. I agree. We don't have perfect data. And at least at this stage, we're not going to get it, but at least that we're acknowledging, they're not big secrets, right? It's something that large scale people know that's happened, right? But that we will at least make some effort in trying to estimate the scale and incorporate that into any sort of cost target we use as part of our risk adjustment efforts.
I think this has been a great discussion. Ian.
Yeah, I don't want to belabor it, but I got to say my own thinking. I came in quite tempted by the concept of risk adjustment. I've seen it actually useful doing qualitative comparisons between like specialists in a single period of time, comparing their performance. But as we think longitudinally and in the context of spending limits, I mean, Richard Cronick has forgotten more than I will ever know about this subject. And but the one iron law I have learned is that coding practices follow financial incentives. And as long as if we're relying on systems that rely on coding practices, we have to keep our eyes on that. And those numbers that Mr. Baylett showed us earlier were really quite striking. So I do wish there were a more refined way of getting that, particularly to address the gaps that this creates in poor communities in this state. But absent that, I think we're stuck with age and sex data. I do look forward to kind of analytics off the HPD on case mix adjustment and what we might or might not learn from that. But I do think we have to just, as a board, next pandemic, we'll know that's a large scale event and we'll have a conversation about that.
Okay. So this was adjustment number 1 of 5 laid out in the statute. I'm going to move on now to 2 and 3. I hope I'm going to move on to 2 and 3. You guys going to advance for me now? I got it. Okay. I got it too much. Okay, so this is what the statute says about quality and equity. So for quality, the spending target shall allow the board to adjust when warranted. Okay, so this doesn't say that there shall be adjustment for quality. It says there should be an ability for you to adjust when warranted, and to adjust two ways. To adjust when a healthcare entity is delivering high-cost care and one is delivering, when it's delivering high-cost, low-quality care and low-cost, high-quality care. Okay, so there is an allowance for doing that. With regard to equity, here it places the onus on the office, not on the board, and so the office shall establish an equity adjustment. So this isn't when warranted, and when information is available at discretion, shall establish an equity adjustment. But data has to be available, and there has to be a validated methodology. I would say that was wise drafting. Dr. Pan, I don't know if you put that in, but if so, it's good language, because really nobody knows how to do equity adjustments right now. Everybody wants to do them, but the science has not caught up with the desire.
Dr. Pan, go ahead.
All legislative activities collective, but as the person who essentially wrote the section, I think the hope is that this will inspire researchers to develop, because as I point out that, a middle-class person with diabetes and a person who is in an underserved community with diabetes may have different costs related because of the communities they're in, the supports that are not available, et cetera. And if we truly want equity, we need to affect that. But I agree, the technology is not there yet. So hopefully this is incentive for all the people listening who want to do research, and maybe the funders who are funders of research as well, to hopefully get people to start working on this. And if they are able to demonstrate they have an effective, we are ready to accept their work and to do that. So yeah, that's the incentive.
Okay, well, I can tell you it's incentivizing OCA and its contractors, as Vishal will describe on the next slide.
So as far as OCA's approach for quality adjustments, we're currently performing analysis to identify data sources for quality measures, and develop approaches for performing quality adjustments. Next slide. And then just want to also call, next slide. Then I just want to, remind the board that they have approval authority for the adjustments pertaining to quality, but OCA will do all the staff work to recommend adjustments.
Oh, sorry, either it does work or it works too fast.
Any questions? I know we in terms of, we don't have a lot of options to share with you today, but just to let you know that we're working on it, and we'll return to the board with the status update in the future.
So a comment on that. Michael said earlier that the risk adjustment wouldn't be used to compare costs across provider entities, or at least I understood you to say that. Maybe I misunderstood.
Well, for purposes of the spending target,
Yeah.
right? It may be for other purposes, but if we're measuring year 1 to year 2, we're using it to see, did an organization's population change?
Right. And that makes sense. On the quality adjustments, the statute talks about high cost, low quality provider entities compared to low cost, high quality. And it seems inevitably to kind of get there, you are comparing across provider entities, and will need some way of trying to adjust for the differences in populations, which may just be the age, gender adjustments that we've discussed. But at that level, comparing provider groups, you might want to try to go further.
Yeah, it's a little more fraught.
I don't envy you.
Thank you.
Or us.
Yeah, just make a comment. I think one of the critical things is that as we're setting cost targets, why definitely don't want to see happen is that we are disincentivizing people to take care of people with chronic conditions, right? Because as every year everyone decides, who am I going to roll, et cetera. This adverse selection problem, et cetera. So we actually want people to embrace. I always said the success of any health reform is that people actually want people with chronic conditions because they figured out how to take care of them better. So that's really the fundamental issue when it comes to, we don't want to create build on the existing disincentive for essentially any risk-bearing organization, health plan, whatever, to take care of people with chronic conditions. And that includes mental health, by the way. So I think that's the caution in terms of saying, like, if we're doing comparisons, we're setting cost targets. We don't want to have someone say, well, gee, I can solve my problem by finding a way to discourage, and there's lots of ways to discourage someone with a particular or a set of chronic conditions and getting them out of my system and someone else's problem.
Thank you for flagging that. So I'll also cover OCA's approach for equity adjustments. Again, we're still in the planning and research phase to identify data sources and approaches for equity adjustments. And we'll return to the board with more information in the future.
Okay, so adjustment number 4 is organized labor adjustments. And this is one where, again, the office shall develop a methodology that would allow the board to adjust cost targets to account for organized labor costs. So I talked earlier about how it's possible to both adjust the target and to adjust performance. This specifically says adjust the target. And so it's quite explicit here. The methodology shall require the board to adjust targets as appropriate for a provider of fully integrated delivery system for actual or projected organized labor costs, specifically for non-supervisory employees, including, not surprisingly, expenditures related to compensation. So in case any of you are picking up on this, there's a little disconnect. The spending target is about payments to providers. This is about input costs for providers. Okay, so they're not exactly the same, but there's some need to make a leap to make them equivalent for purposes of making this adjustment. The adjustment shall be made upon a showing that labor costs are projected to grow faster. So the entity that wants to have an adjustment made has to demonstrate proof or evidence to justify it. And specifically has to submit a request with supporting documentation in a format prescribed by the office. Okay, and then the office can validate it essentially however it thinks it needs to, and can go so far as to audit the submitted data and information. Okay, so this is quite prescribed. The language we just looked at for quality and equity was quite minimal. This is not. This is highly defined and clearly highly negotiated. Michelle.
So as far as what OCA will be doing, OCA will develop a process for evaluating requests for adjustment to the target based on actual or projected non-supervisory organized labor costs, increases impacting the entity's ability to meet the target. This will include work to collect the data, specify the required format, and then validate any supporting documentation. Next slide. And then the board would have the ultimate authority to approve the adjustment.
All right, and the fifth and last of the statutorily defined adjustments is for Medi-Cal.
And Michael,
yes.
At the end of this section may be a good time for us to take our 10-minute break.
Great.
One more.
Oh, you want me to do one more? Oh, I'm sorry. I thought you want to take it there. All right. Well, this will be quick. Okay. So this says that the board, so all of you, to the extent necessary for Medi-Cal to comply with federal requirements. Okay. Not, you know, that's broad language on what those requirements must be, but could adjust targets as they pertain to healthcare entities in the Medi-Cal program, so providers or managed care plans. And I think for this one, I'll just note that we're in early conversations with DHCS on data collection. Right. So let's pause.
Okay, so we will, let's see, 2:37. We'll reconvene at 2:50. Great. Okay, we're back from our break. I don't know if we need to do a roll call or not. Doesn't look like it. Okay, Michael, you're back on.
All right. So, so now I want to turn your attention to some techniques not specified in the statute, but in use elsewhere that can improve statistical confidence and understanding in the results when performance is reported. So states have implemented these strategies when reporting at the payer and provider levels. And only at the payer provider levels, and the reason is because of small numbers. Again, at the state level and at the market level, the numbers are enormous. You don't have to worry about statistical confidence. Very stable. But it's possible that a given provider in a given market, because we're going to be assessing provider entities separately for commercial, Medicare, and Medicaid, that the population may not be enormous. And when I say may not be enormous, I mean in statistical terms. Anybody else would say it's huge, but for statistical terms, not so large. So for that reason, they've taken steps to be able to report so that the impact of random variation is minimized. So these are, in addition to risk adjustment, they are complementary. And there are three approaches. The first is truncation of high-cost outlier spending. I'm going to describe this in detail. The second is use of confidence intervals when reporting results and interpreting results. And the third is setting a minimum threshold for attributed lives when reporting results. Right? So if there is a health plan that has 500 members in the Medicare Advantage market, that might be below a threshold. So wouldn't be reported. Okay, just be specific. The third topic I'm not going to talk about today, but I'm going to focus on truncation and confidence intervals. So let me introduce truncation. So a high-cost outlier is an individual patient or member with extremely high spending in one given year. This is real spending. We want to include it when we're measuring performance at the state level and at the market level. But when we're measuring at the individual payer level by market, and especially at the provider level by market, depending on the size of the payer of the market or provider in the market, those individuals are going to have a significant impact on spend in a given year. They generally present randomly in a population, and that their presence as it waxes and wanes from year to year can have a substantive impact on trend. So it can drive it down one year because last year we had $5 million patients. This year we only had one. So boom, your per capita trend is going to drop down. Flip that around from 1 to 5, your per capita trend is going to shoot through the ceiling. Okay, so that creates a distortion when we are evaluating performance. And could result in the impression that someone did a really great job managing spending growth one year, when no, they just got lucky, didn't have any high cost outliers, okay? And just the opposite. So in the contracting world, it's very common that providers and payers, when they're negotiating a contract for a total cost of care, they put in a provision that says the provider entity is going to have their risk capped at a certain level, meaning any spending above a certain dollar threshold is truncated, meaning it's removed from the calculation of per capita trend.
Ask you about that, Michael. So as you've said, and we all know, a lot of the California market is paid for through capitation. I'm not aware of that kind of truncation in the capitated contracts, but I haven't seen any of those contracts, and I wonder whether it's your sense that it's common. I mean, my sense is it's not, but it's only a sense, it's not data.
Well, so where's this spending going to be heaviest? It's going to be heaviest in hospital spending.
Yeah.
So, but having not looked at contracts, I don't know. In professional capitation, it's probably going to be less of a concern there, because you're not going to, most of the high cost outlier expenses are going to be hospital expenses.
And my sense is, I mean,
and some drugs.
IHA, the data that IHA reports is that the hospital spending is mostly on a fee-for-service basis and not so much covered by capitation here.
If I could, I do know that some plans, I don't know if it's universal, do pooling points. I don't know what basis that is on, whether it's episodic or per person basis or what have you, but I do know some major plans do that.
Yeah, but in short, Rick, I don't know.
Perhaps not precisely on truncation, but somewhat related. So for example, so you have really high cost individual outliers, but you have a bad flu year, you have a good flu year. I remember reading a story where Sutter actually didn't, they reported poor output because there was a good flu year, right? Not many people got hospitalized with the flu. So I realize this may not be directly related to truncation, but we have flu, of course, shows up every year. Is that, well, how would you adjust that? Is that involved
That's
in
not
this?
here.
Yeah, that's
No.
not here. That's what I figured. Okay,
No.
all right. But
No.
but we'll
This is just the impact of individual patients or members.
okay, all right. But eventually we'll have to figure out how to deal with sort of natural variation, right?
Well, I mean, it sort of goes back to our earlier conversation.
Right.
That those things just happen.
Okay. Yeah, I guess maybe hopefully that gets into confidence intervals over time or something. Swings.
Yeah, I don't know that we get it.
All right.
Sorry.
Thanks.
So here's a case example. So there was an ACO, and the high cost outlier spending took them from being below the target to way above the target. And they were also confused because they said, look, we're getting our reports back from the insurers, and they said, we're doing really well on trend, so why do you show us so high above? So we had to do a drill down analysis, and we found in their contracts they were protected from high cost outliers. We weren't protecting them, and we realized it created a big distortion. And so Rhode Island began truncating high cost outliers in 2020, and this is now common practice in a number of states. Not in all, but in a number of states. This is an example of truncation points from Washington. So they set them differently for the three markets. That's not uncommon. I will say that they never seem to be set at the same level in any two states, and sometimes they're higher in one market, lower in another. I can't understand why, but they generally seem to be somewhere in the $100,000 to $250,000 range, depending upon the state.
Are they adjusted for inflation or medical cost increases from year to year?
No.
It seems like it builds in
so
a
they
downward
should.
bias.
Yeah, they should.
Yeah.
They should. But I also want to say, Rick, none of the states have been doing this for very long. So, a lot of them have reported out maybe 2 years worth of data. So I agree, you couldn't keep them that way forever.
And do we know how many cases or what percentage of cases go past their inflection point. So we're talking about 0.1, 0.01, 1%.
Yeah, I have to remember. I think they're talking like a couple of standard deviations. So we're talking really small percentages of spend. If you look at a graphing of spending, you probably all know this. The right tail is so long. So we're talking way, way out on the tail.
We have a comment from Dr. Hernandez. Sandra?
Yeah, actually, that was the question that I wanted to get to, David, which is, you must do this by standard deviations away from the mean, and is that how these numbers, the truncation points, get determined, Michael?
So I've seen states do it two ways. One is by having a standard deviation methodology. The other is the state brings together the health plans and the providers, and they say, okay, where's a fair point to set them, and they do it sort of by consensus. I will say they seem to wind up with the same range of dollar values either way, but those are the two methodologies. One is certainly more methodologically rigorous than the other, but collaboration and buy-in is also part of the game in getting these programs up in some states. So I understand why it happened that way.
So as far as OCA's approach, we're still assessing the use of high-cost outlier truncation. There are some operational issues to consider here with the degree of capitation in California. So we don't have any, in terms of any options that we're assessing it, we are at the initial stages about, first whether to use truncation or not. And then if we do, then, what those cutoffs could be.
Is it possible to investigate? We asked the question, we didn't sure about the answer as to what the nature of capitation contracts, at least large capitation contracts here in California, how they handle this.
Yeah, that's a good question. We're engaging payers and reaching out to a small number of payers to get some technical assistance and kind of know about their data and operational issues for reporting. So that's something we're definitely going to raise with them about how they would do it, or any kind of considerations we should be mindful of.
Yeah, and I'll say the payers have been helpful to us thus far and collaborative, which is good.
Rick?
Thanks. Yeah, I do have concerns about using truncation. I mean, I see, some of the argument for it, but part of the argument is the disconnect between total cost of care contracts that have truncation and then the targets that don't. I don't think that's likely to be a problem in California, although it's a question to be explored. I'd be more in favor. We haven't, we don't have on the agenda for today the minimum size of groups that we want to be looking at. I'd be probably more in favor of erring on increasing the size or the number of patients who need to be attributed. And we're going to get to the kind of confidence interval, maybe dealing with some of the variation through the confidence interval piece. But I mean, a lot of some part of what we want groups to do is to manage high-cost people well. And yes, there is some randomness. I mean, you all saw me hobble in the first meeting. I would be above the truncation threshold this year on the commercial side, I'm afraid. And there is, hopefully I will not be next year. But again, a group with kind of enough patients, it shouldn't matter too much, right? If you have a group with 10,000 attributed lives has presumably got revenue of 80 to 100 million a year. So, a couple of $1 million people can move the trend some. But if you get up to 20 or 30,000 patients, it's not going to move it very much. And I'm concerned about having groups saying, okay, above this level, we don't need to worry anymore.
Well, they may still need to worry for their contracting purposes, right? You're not taking them away from that. And And that's probably going to be a much stronger financial incentive for them than this program. I think ultimately, and when you have some data, this will help, but ultimately this comes down to the implications for performance improvement plans or penalties that you're going to apply to someone, and whether or not and what the risk is that you're going to be applying those sanctions to someone who exceeded the spending target because they had a big increase in high cost outliers. That's the practical implication of all this. And we don't have an empirical answer to that. You are correct that it's related to where you set the threshold for the minimum population size.
Follow up. Certainly an important point, and we haven't talked about kind of single year versus multi-year performance. But I would imagine that, or I could imagine that, when it comes to penalties and sanctions, that there probably would eventually be some consideration to multi-year performance and looking at provider groups or other entities, whatever designated entities, we haven't talked about the entities, but looking at the performance of entities, not just in a single year, but over multi-year period. And to the extent that that's the case, then the argument for truncation is even weaker, because you worry less about 1 year being good and another year being bad.
Yeah, although I'll give you a theoretical. My medical group exceeded 2 out of 3 years, so you're telling me that I'm going to get sanctioned. But one of those years, I had terrible high cost outliers. So then you presumably are going to create an appeals process, and then the OCA staff will have to go through an exercise with that organization to confirm that there were high cost outliers or not. And maybe that's worth doing because it's not going to happen so often. Or maybe you want to truncate high cost outliers so you don't have to go through that negotiation. Ready to move on? Okay. Confidence intervals. States commonly perform statistical significance testing, again, at the payer by market level and provider entity by market level, not at the state level, not at the market level, to determine or to confirm whether or not the spending target was met. I think you all know this. A confidence interval shows the range of values where you can be highly confident that actual performance lies. Again, this is especially helpful with smaller populations. With larger populations, it's not a concern. But when I say with smaller populations, I mean, for statistical purposes, 50, 100,000 can be relatively small if you look at the size of a confidence interval. So this is just a simple visual. So in this example, the spending target is 3.2%. In the first example, insurer A, the confidence interval crosses above and below 3.2%. So regardless of what their actual rate is, and here that little dot is the rate, which would say above 3.2%, we can't say with confidence whether or not they met the spending target, because it's possible that they fell below. In the second example, insurer B, the full confidence interval is above 3.2%, so target was not achieved. And then finally, in the third case, insurer C, the full confidence interval is below 3.2%, so they met the spending target. Okay.
Sorry to keep delaying us, because I know.
No delay.
But
that's what we're here for.
Two things. One, pretty pedantic and professorial, but on the previous slide,
Professor Kronik.
When we say we are 95% confidence interval on the previous slide, that the 95% confident that the interval between A and B contains the rate of spending growth for the entity, we actually know what the rate of spending growth for the entity is.
Yeah.
And that's not quite right to say that. It doesn't really matter, I guess. But I think that maybe the sort of concept is that this entity has 50,000 people that it's taken care of, and spending growth was 4.5%. There is randomness, in any given year. And if those same 50,000 people were being taken care of next year or last year, maybe it'd be 4.7 or 4.3%.
Yeah, right.
That's sort of the minor pedantic. But then, more importantly, you said 50,000 or 100,000 might still have a fairly large confidence interval. And maybe at some future meeting we can kind of see some of that. I mean, 100,000 members probably is going to have spending in the 800 million to $1 billion range. And I think actually the confidence interval will be pretty small.
Well, yeah, so I should talk about what do I mean by large or small.
Yeah.
I really mean how narrow is it around the observed point for the rate?
Yeah.
Okay, so even at 50,000, let's say, there's still going to be some space on both sides.
Some, yeah. When you get up to 100,000 members and 800 million to $1 billion of spending, you put those 100,000 people through next year, it's probably not going to be too much different.
Yeah. But we actually did a little exercise for OCA where we took actual spending for a health plan in another state, and we just changed the size of the population and graphed the confidence intervals. So it's all plottable.
So as far as OCA's approach, we're still looking into this issue and still determining whether doing our due diligence on this, whether this makes sense. In doing so, we're also going to consider the just as I mentioned earlier for truncation, the use of capitated payments and how this intersects with confidence intervals as well.
Yeah, and we think that capitated payments are going to reduce the size of the confidence intervals in California relative to other states. So that helps. That's going to increase the precision of your measurement.
Sorry, I'm going to go back a little bit to truncation and just listening to Professor Kronik. I mean, it's just Richard. All right. Okay. I guess because we're talking about setting a threshold, right? And my concern is now probably the average would still be too high and would still reflect, but I'd be worried about exactly how many people, right, are we talking about? And I realize you could use the standard deviation set, so therefore it's going to be just this percentage. But if there's a lot of people who's over the threshold, that makes me really worried. So that we're missing something that's going on by basically, they're over truncation levels. So if it's truly like, it's a small number relative to the then that probably is maybe certain level of randomness, but I just I almost hate to say here's the threshold and we're not going to do some careful assessment. How many people actually pass that threshold and why is that? Especially if it starts getting to be a largish number. So are we missing something and missing an opportunity? Is there some behavior that's leading to that, et cetera? So I don't know, just a little reflection on the truncation.
Well, I like thinking about Rick as the case example, right? You called yourself out, right? The likelihood that you're going to be a high-cost outlier next year is quite small, right? Or ever, right?
And if we were to if OCA does, decide to do truncation, we would want to get the data with and without truncation, because we'd be very interested in knowing how many people cross that line, and we'd want to ask the plan about that.
Yeah, and just to Dr. Pan's question earlier about, a good flu season versus a bad flu season, and Michael talked about this, but any entity that exceeds the cost target, the first thing we're going to do with them is have a conversation and look at the data together and try to understand what that is. So, you know well that there's the 4 steps of progressive enforcement and that it's starting by understanding the data. And if there's a good reason, whether it's, something like Sovaldi happened or it's a bad flu season, and that explains it. There's no interest in having an onerous enforcement mechanism in that context, but to understand it.
Yeah, no.
So we don't need to adjust for everything ahead of time because there's an ability to look at it on the back end.
Yeah, I'd also point out that if it was a good flu season, we don't necessarily have to give a pass to everybody if their baseline flu costs were lower, and that so therefore I'm just trying to there's certain parts that there may be, and again these are population level events, at least they would affect regional if not potentially statewide, that there's these variations that we might be able to at least have some ability to assess their magnitude. That it doesn't mask other things that are going on, and so whether on the upside or the downside, right? So it just something to think about. Obviously, COVID's not the whole nother scale, but even just thinking about flu and just thinking about when I read news reports about a hospital had a good year or bad year this year, and then they cite the flu season, I'm like, oh, okay, so it does have enough of an impact on the financials that at least business reporters are reporting on how it's affecting the performance of certain entities. So just again, something throw on the table to think about.
And some of these things, as the HPD matures, you'll be able to track using it. I mean, just the other day, I was looking at a state's dashboard that sits on top of its HPD, and I went in and I was looking at inpatient spending by condition category, and I went to respiratory, and boom, I could pick out the DRGs that were COVID that I didn't see in 2018 or 2019, and then they were high in 2020, and then a little lower in 2021. And so it will be possible to do that type of analysis, hopefully in a future mature state of HPD.
Well, we have a comment from Dr. Hernandez again, Sandra.
Yeah, I was just going to comment on this issue of truncation, and one way that OCA may want to think about that is to not initially do any truncation. Where there's a case of an outlier, you will sit with the plan or the provider and know the details of that, and decide based on that information that in fact is an outlier, without trying to beforehand try to understand where to put a truncation line in. So that would just sort of be a learn as we go approach to truncation, and get a little bit of more concrete examples of where there are 1 or 2 outliers in a particular year, before you try to understand where a truncation might work beforehand.
Yeah, OCA could also, for the baseline, have the payers report with and without truncation, so that you could see what differences it make.
Mm-hmm. Mm-hmm.
All right, I think that is our content.
I think that is it. Michael, thank you very much. Any other comments or questions for Michael Bailett? Okay, we'll now go ahead and invite public comment for this section.
All right, we'll now recognize public comment. For folks attending virtually, we remind you to raise your hand, or if you're calling in, press *5. Looking to the room, we'll go to the podium.
Beth Capel on behalf of Health Access. We apologize for getting our letter in a bit later than we would have liked. With respect to risk adjustment, we would concur that coding practices follow financial incentives. We cite in our letter the example of a rather large health system that in the individual and small group market is consistently found to be very healthy, and amazingly, in the Medicare Advantage market, has recently been accused of egregious upcoding. And although turning 65 may somewhat increase the disease burden, it probably didn't do it quite that much. And so we would support the staff recommendation to use age and sex, or actually even no risk adjustment, given the experience in other states. We would also suggest when you look at the regional and statewide level, you might want to consider some additional factors. You can count us as skeptics that you're going to find low-cost, high-quality providers. We appreciate that the language says when warranted, because we're skeptical that that exists. But it's in the law, so you will look. With respect to truncating high-cost patient outliers, for many of the reasons that Dr. Pan has already discussed today, we oppose simply truncating them without further examination. Whether it's long COVID or infant mortality varying by race, there are good clinical, and we also think back to the early years of the AIDS epidemic, there are clinical reasons why there can be high-cost patient outliers that are not random. Similarly, we cite a number of examples, one in particular where there was an outbreak of kwashiorkor in Reading, something that was known to the state government, but which took no action until the Federal Bureau of Investigation showed up. There was also excessive utilization of cardiac procedures, hysterectomies, and numerous other procedures. So part of the role of OCA is to have oversight of the healthcare system and to look for these kinds of outliers. And simply truncating for statistical purposes does not strike us as sufficient. We would also concur, and I think Dr. Pan raised it, but it's been in the conversation. We'd want to know how many claims we're talking about. Are we talking about 0.1% or 20%?
10 seconds.
Yeah, Tom. So I think that's important. The discussion about an ACO in Rhode Island, I'd be curious what population you were talking about, to Dr. Kroenik's point. You know, there are a small number of hospitals there. We have more than 400. It's kind of a different world. So that is a very different conversation than the one we're going to have here. So thank you. And most of this is in our letter already, so appreciate it.
All right, looking virtually, seeing no hands raised, going back to the podium.
Thank you. Beth and I agreed we're going to go on the road. Hector Flores again. I just wanted to highlight some issues maybe regarding small area variations that you should take into consideration when we're looking at the more global picture. One is that when maybe adding disease conditions or institution-specific disease conditions. For example, children's hospitals carry a huge burden with children who qualify for California Children's Services. And they have many physicians in the community who are affiliated with them who actually end up inheriting those patients when they graduate from the CCS program. And we need to be able to be cognizant of that small area variation based on the institution and those who are affiliated. The second thing is, there's something called a Healthy Places Index, which looks at zip code. The zip code where we live may determine more about our health than our genetics. And that is really important. And a classic example of that is a colleague of mine has an IPA in South Los Angeles. And when Medi-Cal expansion occurred, everybody thought that there was just this healthy population that was a financial boon to the IPAs. And it was in many other areas, but not in South Los Angeles, where her patient population for expansion was people with mental health disease, substance use disorder, and other high-risk conditions. And when she did ACEs screenings for the adults and children, they were, through the roof. So important to keep that in mind. The other part of this is on the truncation side, there's a confounding variable that IPAs and health plans buy stop-loss insurance for those high-expense populations. So we need to be able to make sure that we take into account the cost that may be hidden there. And lastly is the kind of artificial low utilization, low cost
10 seconds.
that it should be for SPD, seniors and persons with disabilities. Nobody wants to take care of them, so they bounce around from facility to facility. They're costly, but they get hidden in the spread of the risk. And when they graduate, they age into Medi-Medi, everybody loves them and starts coding how severely ill they are. And I think it's important to keep that variation is so they don't suffer when they're SPDs before they get to Medi-Medi. Thank you.
Looking virtually, seeing no hands raised, going back to the podium.
Hello, Ben Johnson from California Hospital Association. We appreciated the more in-depth conversation on possible adjustments to the cost targets that were had today. Believing public deliberation, stakeholder input is essential to making sound decisions when it comes to setting and enforcing the cost targets. And we really believe that the office should be laying rules of the road that target their activities at costs that healthcare entities can control. And an important mechanism for doing so is to assess and control for random variation, such as through the methods that were discussed today, to ensure that healthcare entities aren't arbitrarily falling into the enforcement process. So we are encouraged by the discussion of confidence interval approaches, truncation approaches, and so forth. Second, we do remain concerned that risk adjusting based on just age and sex could have incentives that really discourage providers or health plans from treating the most needy, as was concerns I think that were aired during the discussion. And so would look to, continue discussions around those issues, understanding that upcoding can be a concern, but there are other critical factors that I think the board should ultimately consider in making these decisions. And ultimately, just the discussion just on the age and sex reminded me of the sort of critical importance of these overall shifts. Sometimes they're shocks, such as COVID-19. Sometimes and other times it's really just the gradual changing in society. 65 and older folks are expected to grow over 150%. Over the next several decades, while those under 65 are going to grow at a much lower rate, less than 20%. And this is going to have profound impacts on the costliness of California's healthcare system that ultimately need to be accounted for in the deliberations of the office and board. So thank you very much.
Moving back virtually, looking for any hands raised. We'll give it a moment. If you're dialing in, please press *5. All right, seeing no additional virtual comment and no one else in the room at the podium.
Well, thank you. We are now at the end of our agenda, item 6, which is general public comment. And we'll now invite general public comment to the entirety of the agenda.
Moving to general public comment, we will start with virtual. We have one hand raised. Harvey, we will unmute you. Please go ahead.
Hi there, my name is Harvey McKeown and I work for the Carpenters Union in Northern California. The Carpenters wish to express appreciation firstly for the formation of OCA and its legislatively defined remit with regard to eventual oversight over premium rates. We believe that for too long, consumers have been subjected to rate increases without adequate knowledge of insurer claims, pricing, and finances, and the NorCal Carpenters Union is not going to stand idly by either during this or future rate renewal cycles without pursuing a fuller understanding of medical organization business models and the systems and practices that sustain it, including strategies pertaining to for-profit growth and insurer acquisitions in new markets. And indeed, I really appreciate all the earlier presentations and discussions regarding consolidation. So glad to see that's on our respective radars. In any case, the Carpenters intend to remain engaged with this body and look forward to future discussions on some of the matters I've touched on in my brief statement today. So thank you for receiving these comments. The Carpenters stand in solidarity with other consumers subject to currently opaque processes regarding healthcare pricing. Thank you very much.
Moving to public comment in the room, going to the podium.
Good afternoon, folks. I'm Steve McDougall, coming from Monterey County. I'm president of council of ECTK through 12 educators throughout the state for the California Federation of Teachers, and a past president of Salinas Valley Federation of Teachers, and also a trustee with a now defunct trust that we used to have our health care benefits delivered through before the one that we're in now. And at one point, I found out the costs of 3 hospitals in Monterey County through our network. 2 were over $12,000 per night inpatient. One was $17,100 per night per patient. Scheduled a meeting with the CEO of that facility. After 15 minutes of him droning on why he needed to charge what he charged, I said, enough. In 2 days, 48 hours, you're going to get a registered letter from our network demanding to negotiate. If you fail to do so, we'll slap a surcharge on this facility and we'll send all our folks across town. At which point he referred to me as perhaps not a teacher, but an organized crime labor leader of yesteryear. I don't want to offend any of our siblings in a union that he mentioned from the past. And I said, be that as it may, if you fail to negotiate, I don't write an op-ed letter every day to the local media outlets, but I'm batting 1,000 on getting published. At which point he said, have your person call my person. And we had significant savings to our plan for that facility for the following year. Why am I saying this now? It was 2013. What are we charging now? What are we paying now? We don't know, because our current network has confidential contracts with the hospitals. We don't get to know, even though it's our money, our compensation, we don't get to know what the cost is per night.
10 seconds.
And that's not okay. That's got to change. The problem in Monterey County is going to happen everywhere else if we don't get control of costs. And I appreciate your work and thank you for your time.
Looking virtually, seeing none, going back to the podium.
I'm a little bit shorter. Good afternoon. My name is Katie Bassler. I'm the president of Salinas Valley Federation of Teachers. I too came up from Monterey County today to speak to all of you because there is so much to be done in Monterey County to control the cost of healthcare that impact the members of my union, but so many others in our community. Online, you will post a flyer that I brought up. And what I am highlighting is how our healthcare trust has carved out the hospitals in order to control cost. So what I have here is a chart of 3 plans. The richest plan, which costs $30,000 a year in premiums in Monterey County for folks to be able to access the 3 hospitals. Then another plan that has a very high deductible and out of pocket, but allows them to access the hospitals, and those are $26,000 a year in premiums for a family. The plan that carves out these 3 hospitals, and it is the plan that I stand for and I advocate for, costs a family $18,000. It is the only affordable plan for families, especially educators who want to build a family in Monterey County. These 3 hospitals are unchecked. What Steve McDougall mentioned earlier about the facility cost, we have no idea what it is, but we just tell folks, go out of the county and get your health care elsewhere. As you do your work, please don't forget about Monterey County, because if you cap or you control the costs are already out of control down there.
Seconds.
We need some control of these hospitals. Thank you very much for your time and the work that you do.
Looking back online, reminding folks to raise your hand if you'd like to make a comment, or if you're calling in, press *5. Seeing no virtual public comment at this time and no additional public comment in the room, that concludes our general public comment.
All right, well, that brings us to our final agenda item, which is adjournment. And we've concluded our agenda today, so therefore the meeting is adjourned. Thank you all very much.
Thank you.